Oh, great. Thank you, Tarana. So yes, welcome to the Mental Health Promotion Knowledge Exchange. The intention of today's knowledge exchange is to discuss the OCASI Mental Health Promotion Project, its accomplishments, as well as the challenges we faced over the past year, and to bring together stakeholders from across the sectors of settlement, primary care, and mental health to share experiences and engage in discussions on how we can continue to build organizational capacity to address client and staff mental health, and how we can become trauma and violence informed in the work that we do, especially in consideration of the many structural and systemic issues that have been impacting our work in the sector. So before we get going, one second, there we go. I would like to begin with acknowledging the traditional territories of the people of Turtle Island. The sacred land on which we are gathered today has been a site of human activity for 15,000 years. We acknowledge that the land we live and work on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. This territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Haudenosaunee and the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. We also acknowledge that Toronto is covered by Treaty 13 with Mississaugas of the Credit. So I wanted to begin by going through the key objectives for today. So the key objectives for this virtual conference are to learn about the experiences, challenges, and successes in implementing the mental health promotion integrated service model, to share knowledge and learn strategies on how to implement trauma and violence informed approaches at work, to engage in discussions, brainstorm, and plan for the future of mental health promotion in the settlement sector, and to enhance cross-sectoral collaboration between settlement, primary care, and the mental health sectors. So to just briefly touch on the agenda for today, we're going to begin with an overview presentation of the journey of the Mental Health Promotion Project. Then this will also include a presentation by Zohra Gillani, who is a manager from Catholic Crosscultural Services, which was one of our implementation sites for the mental health promotion model this year. So she's going to talk about the experience of implementing the model. Then we'll have time for question and answers based on our presentation. And then following a wellness break, we will have breakout rooms and group discussion to discuss some of the challenges that we are all facing around staff mental health and organizational capacity these days. Then we will have lunch. And then we're hoping that you can all join us again in the afternoon. And in the afternoon session, we have two exciting webinars. The first webinar will be Trauma and Violence Informed Care, a primer for the settlement sector. This will be followed by a break, and then a following webinar, which will be formatted like a panel discussion. And the second one is Trauma and Violence Informed Care, Implementation and Practical Implications for the Settlement Sector. So these two kind of go off of each other. So it'd be great for you to be able to attend both of these exciting webinars in the afternoon. And then we'll have a closing wellness activity. So we're very excited for today and so happy you could join us. To just briefly touch on engagement and self-care, we understand that virtual events are a different experience than in person. So just a few things to keep in mind as we go through the day. Please say hello and share your thoughts and questions throughout the day in the chat. There will be opportunities to raise your hand, unmute, and speak up. But with that being said, during the presentations, if you have any questions that come up, please just write them in the chat. We'll be keeping track of all the questions and collecting them so that we can address them during the Q&A at the end of the presentations. There will also be an opportunity to speak up during the breakout rooms later in the day. We understand that Zoom fatigue is real, so do what you need to take care of yourself throughout the day. We would love to see some faces though, so maybe even just during the group discussions, if you could turn on your video briefly, we'd love that. But yeah, stay present and be attentive to your body and your emotional needs. We are striving to create a trauma and violence informed virtual space that is safe and inclusive for all. So please participate at the level you feel comfortable and don't hesitate to reach out if you need any support. Now, I just want to briefly introduce Carolyn Ellis. She is from Brilliance Mastery, and she's been at the last 2 knowledge exchange events. We're so happy she could join us again. And she is going to be doing a digital recording, or you could call it a visual graphic summary of each session that we have today. So during our breaks, I'm going to have her screen share, and you'll be able to see her work in progress and see kind of the graphic visuals being created, which will be really great. So yeah, I think without further ado, we can begin. Just get the slide going. So now I would like to introduce my colleague, Sajide Zarai. She is the Senior Manager of Professional Development and Training at OCASI.
Thank you, Kaylee, and good morning, everyone. Welcome. We're very pleased to have you here as part of this event. It's wonderful to see so many people joining us. Hopefully, you will be able to stick it out for the entire day. I think it will be a great discussion, and we will be very happy to have you contribute to improving the project as we go along. So next slide, please, Kay. The mental health promotion project, I'm just going to give a quick overview and go through some of the visual summaries that Carolyn has created over the last few years that we've been working together. So initially the project started as a service delivery improvement initiative funded by IRCC for 3 years. And this is the second phase that's also been funded by IRCC until 2024. And each year we are working with 2 agencies to implement the model, and we do continuing capacity building activities. This is the list of existing current partners that are contributing to the project and many of them have been with us from the beginning, from the time when we submitted the proposal to IRCC, and have supported the development of the model that we will be talking about today. And several of the agencies have also implemented the model and continue to participate in providing capacity building activities and sharing their experiences. As you can see, this is a cross-sectoral partnership and advisory group that we look forward to every month. Next. So this is a visual slide from the first knowledge exchange event that we did in February 2020, which was the last in-person event that we were able to host. And this visual summary provides sort of an overview of the project. We started with a needs assessment and an environmental scan to identify what are the needs and issues facing immigrants, refugees, non-status people in the settlement sector, as well as the mental health needs of the staff who support them, recognizing that the staff also face many of the issues and challenges that their clients face, because many of them are also newcomers themselves from various professions who ended up working in the settlement sector. And so you see some highlights from the needs assessment here. In the interest of time, I won't be able to go through it all. I wanted to focus on the model. As you see in the left-hand corner, this is the model that we created with the clients in the center. So it's a client-centered, integrated model of mental health promotion that looks at various aspects. It's an organizational change model. And we take a comprehensive approach in working with the agencies to look at client mental health, staff mental health, the organizational capacity, and how we can support them in developing policies, protocols, providing training, and supporting them in developing partnerships and collaborations with the primary care sector as well as the community mental health sector. And some of the lessons learned, and you see that this is a continuing theme in terms of leadership commitment and buy-in, engagement at all levels of the organization, the importance of
Because it
systemic
didn't work, so I
structural
have no other
change.
option. It doesn't work.
Can you hear me? Sorry, somebody's speaking. If we could all mute, that would be great. And ongoing knowledge exchange and collaboration. Next, Kelly. And this is the slide from the implementing agencies that work with us, the first two implementing agencies, Rexdale Women's Center and Polycultural Immigrant Services in PL, who worked with us in piloting, implementing the model, and sharing their lessons learned. And these two agencies focused their intervention on women. Through the needs assessment, we identified that refugee women or newcomer women with experiences of trauma and gender-based violence were the priority group. And we, through working with them, we also developed the trauma and violence-informed care guidelines, and following developing the guidelines, we translated them into French and developed an online self-directed course that we continue to offer to people. And you see some of the lessons learned here that were shared at the time. I won't be able to go through them. The next slide, please. So these were the first two sites were the only two sites that we work with them in person. And since then we've implemented the model with 4 other organizations, but all of our work has been virtual. And it's amazing how much time and commitment and creativity went into it to be able to implement the model and its various aspects virtually. So Mennonite New Life Center and the neighborhood organization were the next 2 sites that we worked with in 2021. And the focus of this was working with newcomer youth. And we trained newcomer youth to provide the peer support model that I believe they have continued to offer these groups on an ongoing basis. And you see here some of the perspective from the youth that was shared. And one of the challenges that these organizations faced, and I think not just this, the next set of organizations as well, because of COVID and because of doing the work virtually, it was really challenging to recruit youth from the organizations because the workers weren't going in person and we weren't seeing the youth. The agencies were not seeing the youth in person, so that we had to be really creative, and the youth tried to reach out beyond the youth that were participating in the specific programs to be able to run these groups. Next. So over to you, Kaylee. Kaylee will be sharing experiences from implementing the model with these 2 agencies.
Thank you, Sajide. So over the past year, we have implemented the mental health promotion model with Catholic Cross-Cultural Services, CCS, as well as Dixie Bloor Neighborhood Center, DBNC. I'll just make a quick note that we were delayed in starting our implementation. So technically, we would have been implementing these at these agencies for the fiscal year 2021 to 2022, but because of the delay, we started working with them in the spring of 2022, and we worked with them through this past fall. Okay, one second. Yeah, so just to give you a bit of an overview on the needs assessment purpose and the approach that we take when implementing the model at the sites we work with. So the purpose of the needs assessment is to really learn about the current state of mental health promotion at the agencies we work with. So we're looking to see what current programs and services, supports, policies exist around mental health promotion, as well as are there any partnerships in existence. So we are looking to identify what gaps exist in the provision of services and potential areas of improvement for client and staff mental health. So in terms of what we do for the needs assessment, as we start our work with the agencies, is we run focus groups. So we run focus groups with the clients, the staff, and the leadership or management teams to really get a sense of what the current state of things are at the agency. We also review organizational documents, and we also disseminate a staff wellness survey, both at the beginning of model implementation and at the end, to get a full picture of what changes over the course of model implementation. So I wanted to provide just a brief overview of some of our key findings from implementing the model at CCS and DBNC over the past year. So newcomer youth were identified at both agencies as the target population, and that really means that the population was identified as being the most underserved in terms of mental health support, and also the most in need of mental health support at this time. So many of the key findings had to do with youth feeling, how they were feeling during the pandemic, especially when schools weren't offering in-person learning. So many of the youth had or continue to feel socially disconnected, but also uncomfortable disclosing some of their mental health concerns with friends and family, kind of showing us that there was some internalized stigma around mental health, experiencing heightened anxiety, social isolation, but not really having anyone to turn to while also desiring more social connection. In terms of staff mental health, some of the key findings were around increased burnout as a result of the pandemic, compassion fatigue, staffing shortages, and high absenteeism were some of the main issues that were leading to even greater burnout and burden on the existing staff. So many staff have had to leave on extended leave due to the workload burdens. And then there's also just been a lot around challenges between personal life responsibilities, caregiving, and work responsibilities, which has really been heightened during COVID. There was a lot that also came forward around the transition back to the office, and that hybrid or in-person model causing increased anxiety and stress for many staff. And I do want to note that the challenges that are occurring at the partner agencies are really reflective of more generally what's been happening across the sector right now, especially coming out of the pandemic. In terms of organizational capacity, all the agencies we've implemented with have expressed a need for developing mental health and trauma and violence informed policies and practices on an organizational level. There was also a lot that came up around staff wanting more training on how to identify mental health concerns and how to respond to mental health concerns that occur with their clients, and also around crisis intervention and what kind of response is appropriate, and clear guidelines and resources for the staff as to how to handle crisis situations with clients. Finally, in terms of collaboration and partnership, there were many barriers that came up around successful mental health referrals, especially in terms of finding cultural and language specific mental health support for newcomer and immigrant and refugee clients. Long wait lists and geographical isolation were also major barriers to successful referrals. And then there's also the ongoing need to develop cross-sectoral partnerships, and this continues to be a gap in this project, which we will touch on more. So in terms of implementation activities, having seen the key findings, so we helped each agency by providing CMHA peer support training to newcomer youth, which the agencies could then use to implement their own peer support group with the newcomer youth at their agency. In terms of staff mental health, we helped each agency establish wellness committees or enhance existing wellness committees. And additionally, from the staff wellness survey, they were able to have the data on what staff were really wanting to implement around staff wellness initiatives and use that to enhance the wellness committees that were established and plan ongoing activities. We also, this past year, initiated a staff peer support group, so adapting the CMHA peer support training model to train staff from each agency. So we also train staff on facilitating their own peer support groups. And additionally, we provided trainings to both agencies on topics related to staff mental health. And for example, one of these was the working mind, which we offered a couple times throughout this year. And that training in particular was really focused on developing leadership capacity to be responsive to staff mental health. We supported the development of mental health and trauma and violence informed policies at the agencies we worked with. And this is more broad because another element of this project is offering capacity building trainings for all of the immigrant and refugee serving agencies in Ontario, but we did provide 19 training opportunities and trained approximately 745 participants on a variety of mental health related topics throughout this past year. We do have an advisory committee, which I think Saturday mentioned before. So we have many project partners who are also helping to enhance the collaboration and also act as kind of like a sounding board to the implementing sites. So we were able to have monthly meetings where the new implementation sites could seek advice and lessons learned from the past implementation sites. That was also very helpful. We also supported agencies with creating environmental scans to help them identify potential partnership opportunities. Just briefly, I'll just touch on this is from the youth peer support group that was implemented at CCS. I won't say too much because Zohra will be presenting shortly to give a more full view of what they implemented, but the results indicated that newcomer youth client mental health was improving through participation in the peer support group. These were some quotes from the participants. And one was actually from a service provider, but you can see from the quotes that it was beneficial to the youth's mental health. Just to say a few more words on the staff peer support group, which was implemented at CCS. So we did train 3 staff at CCS to run a peer support group, and they delivered 6 mental health promotion activities, including 2 all staff sessions. And you can see below, these were some of the topics that they focused on in the mental health support group for staff. This is just a chart that shows some of the trainings that we offered throughout this past year. So as I mentioned, these were trainings that were offered to the sector as a whole. We also have an OCASI Trauma and Violence Informed Approach course, which is a self-directed course, which we offered twice this year. But as you can see from many of the topics covered, from mental health first aid, coping with loss and grief, compassion, fatigue, vicarious trauma. We worked with Mental Health Works on building a trauma-informed workplace. So all of these topics were really based off of consultation with our advisory committee as to what some of the major topics were that we wanted to address, what some of the needs of the staff and clients were at this time coming out of the pandemic. And that's what we focused on with our capacity building activities. And this chart shows that, that the percentage of change between pre and post surveys indicates that participants' knowledge and comfort around dealing with mental health increased as a result of the trainings. Finally, I just want to briefly touch on some of the key challenges that came up with implementing the mental health promotion model over the past year. So around client mental health, we did encounter some challenges with outreach and timing. Recruiting newcomer youth to participate in the programming over the summer months was a challenge, along with scheduling the programming at a time that worked for them. We also had issues around accessibility, if there was a lack of transportation due to geographical barriers for the youth to attend programming. And there was also the question of, is the group sustainable long-term? And do the youth have the capacity to continue to facilitate the group? And does the agency have the capacity to provide ongoing support? In terms of staff mental health, some of the major challenges we faced were around establishing wellness committees and planning wellness activities for staff, because while we saw them as beneficial, we didn't want to overburden the staff who were already experiencing burnout with extra responsibilities to plan the activities. However, we do want staff involvement to be able to plan the activities. So that was an ongoing challenge we faced. And then more structural issues around staff turnover and staffing shortages greatly impacted the ability for us to implement all aspects of the model this year. And then lastly, around collaboration and partnership development. It was difficult for agencies to be developing cross-sectoral partnerships with mental health and primary care at this time, especially with the human resources crisis going on that has really destabilized the healthcare system. So it was hard to get engagement from these two sectors. Even just in terms of our advisory committee engagement, it was challenging. All right, so I am now going to stop sharing my screen. 1 second. Goodness. There we go. And now I'm going to hand it over to Zohra. I would like to introduce her first. So Zohra Gillani is a settlement services manager at CCS, Catholic Crosscultural Services. She manages both the settlement workers in schools, SWIS, and mental health and wellness program. Utilizing her background in social work and psychology from the University of Waterloo to drive their success, over the past 16 years, Zohra has made significant contributions to the management, development, and innovation of programs aimed at helping newcomer students and families smoothly integrate into Ontario's school system and communities. She is a strong advocate for collaboration, and as the chair of CCS's Social Wellness Engagement and Learning SWELL Committee, she actively works with her team to foster employee engagement, improve staff mental health, and cultivate a positive work culture. Welcome, Zohra.
Thank you, Kaylee. Good morning, everyone. Kaylee, can you just confirm if you can see my screen? Yes?
Yes, okay. Yes, that's great.
All right. So hi, everyone. My name is Zohra Gillani. You've just had an introduction, so I'm not going to go into this. We've been very fortunate to have had this opportunity to be able to implement the OCASI Mental Health Promotion project at CCS. And I could talk about this forever, but I only have 10 minutes, so I'll be very quick because a lot of the information has been provided by Kaylee and Sajide. So our journey from ideas to implementation, we have mental health and wellness workers in both our CCS regions, both in Toronto and Peel region. And we are a fairly new department, I would say about 3 to 4 years. When I say new, it's also because 2 of those years have gone to COVID and there wasn't a lot of growth that we had wanted to do in the program. But going back, I think around 2020 is when we started, and I remember we met as a larger department at CCS, all our mental health workers and all the managers managing the programs. This was December 10th, I just remember, because it was the first time that we had met after a very long time. And we were discussing ideas around how we can develop our mental health programs and really have a more holistic view of how we want to do this for our staff, for our clients, and how to continue to build collaboration. So some of the ideas that we had back then, before we got into this project, was to reduce stigma and normalize mental health conversations with our clients, with our staff, also to integrate regular mental health check-ins in settlement service delivery as part of settlement needs and not leave it to a crisis for a client to connect with the mental health workers. Also to enhance our needs assessment tools, and a lot of us who are here who are primarily settlement service providing agencies with mental health components, we know that we have our own tools that we do need assessment with, but there is no connection to OCMS, which does make it difficult for us to then have to enter information on multiple tools. So that is something we wanted to iron out. Also to build mental health programming for youth, establish rolling mental health support activities to continue to foster a positive and supportive work environment. We also wanted to develop risk management training and add on practices that prioritize mental health at the agency or at our organization, and to build our community collaborations because we were just in the initial stages of doing that. And then lo and behold, a couple of weeks later, I received an email from a colleague who's been part of this project before from TNO. And everything that I've just said was a perfect fit. All of this is what we wanted to do, but what we were struggling with, how do we divide up this work so that we are able to accomplish all these goals and then be working towards them. And then we've also already mentioned, you know, as staff, we already have so much on our plate. It's very difficult to take on additional initiatives and to bring them to fruition. So we then connected with the OCASI Mental Health, put in our proposal very, very quickly. And we had Kaylee and Sajide connect with us and go over our proposal. So it was a quick process. So one thing I would like to say is that, oh, not yet, 1 second. So one thing I would like to say is that what we were missing, we had some ideas and we just needed some more ideas around how to really bring all of these plans or ideas that we had and to sort of implement them at the agency. With Kaylee and Sajide, and I sometimes feel people probably think I get paid to say all these things for them, but they're really wonderful and I don't get paid. They're really wonderful, and what they really helped us do is take all the ideas that we had, bring in more information from their learnings in the past out of this project, and they gave us a perfect plan under 4 areas that we were going to talk about: client mental health, staff mental health, organizational capacity, as well as collaborations. So we had a perfect roadmap of how what we have to do and how we may be able to get there. So based off of that, and obviously all of these initiatives were informed by the needs assessments that were done with our leadership group, our clients, which youth, and our staff at the agency. Under client mental health, like we had proposed, we wanted to enhance mental health and wellness support for newcomer youth. We have a huge newcomer base because we are also one of the leading agencies in Toronto doing the Swiss program. So we have a lot of access, or great access, to youth in our school system, both in TCDSB and TDSB. So through that, we were able to implement a peer-led model that supported the mental health needs of newcomer students in our summer camps, in our Now and Win programs. Some of you who are here from Swiss would know what those are, but they're really school preparation programs. So through that, we were able to integrate a very solid mental health curriculum in our programs for our newcomer youth. This is Isabel here. I'm just going to quickly play this. She was able to send me a quick video, and she was one of our top peer leaders. So I'll let her talk for 1 second.
And I was a facilitator for OCASI's Mental Health Program last summer. My experience was generally a positive one. It definitely required a lot of planning and organization in order to create the program and workshop, but I do think the workshop themselves was rather effective because we did try our very best to make it as engaging as possible. So we were able to have some very meaningful conversations with some of the participants. I think our biggest challenge was probably the lack of structure in the planning processes, because me and my partner had to come up with a lot of the themes and materials ourselves. So sometimes we were unsure whether or not it would be good enough for the program. But other than that, it was a very meaningful experience and lots was learned. So I'm very thankful. Thank you.
All right. So yes, we had great success with our youth peer-led model, and we are now, because of that learning, we are definitely going to be implementing it again this year. So whatever learning we've had, we will be replicating it this year, and moving forward, we'll be able to sustain it. For our staff mental health, we already have a SWELL committee, or had a SWELL committee at CCS. SWELL stands for Social Wellness, Engagement and Learning Committee at CCS, which is basically a social committee at CCS that's been that's been growing over the past 4 years. And this was a great opportunity for us to discuss the additional burden that our SWELL committee has in terms of doing regular day-to-day tasks in terms of our jobs and portfolios, but also we're really, really committed as a committee to be engaging staff and developing initiatives that cater to the wellness of our fellow employees or co-workers. And we've done a lot of that through COVID as well. So I think one of the good things that came out of this conversation and this project is that we did speak and discuss this, and we did manage to scale down our swell committee just to deal with the social and wellness aspect of it, instead of taking into account all the 8 factors around wellness, because that was then also, that was already then shared with other committees at CCS. So that was great. I have here Janodini Thiageval. I actually chair the swell committee at CCS, and this is my co-chair who really supported the peer support groups, and I will just play her insights in a bit.
The Ontario Council of Agencies Serving Immigrants and Catholic Cross-Cultural Services have worked together over the last several months to implement the mental health promotion service delivery model. In our efforts to further prioritize staff mental health, we added activities to our existing SWELL committee, which stands for Social Wellness Engagement Committee. Collaboratively, we piloted and developed the SWELL Peer Support Chat Cafes. The Peer Support Cafe sessions have served as a safe and common platform for frontline CCS staff members to connect, share a space, learn from one another, and find meaningful and practical ways to care for our personal wellness. The peer support cafes have been typically taking place 1 to 2 times per month and have been held virtually during lunch hours. The topics and format of these cafes were based on the findings of the staff focus groups and surveys conducted by OCASI and CCS Well in the summer last year. Some topics include self-care, healthy eating and meal planning, accountability groups, therapeutic and expressive arts, and building community within CCS. OCASI had conducted a training for our peer support leaders on how to effectively run these peer support sessions. I will be going over a few of the chat cafes that we delivered over the past few months. Our first session was on self-care. In this session, staff had the opportunity to share the types of self-care methods they practice. The activity facilitated some excellent discussion among participants. Staff connected and inspired one another while discussing the many unique and supportive self-care practices. This was a good reminder to our participants that there is more than one way to practice self-care, and exploring alternative ways to care for themselves would be beneficial. Our mental health worker also shared some awe-inspiring videos, which were new for most participants. It reminded them to enjoy the natural gifts of nature that are already available to us. Our second session was on affirmation art. Affirmation art can support us in overcoming limiting thoughts and behaviors, building confidence, and increasing one's well-being. The following 4 chat cafes included a 4-part series of mindfulness sessions. One of our facilitators put together this 4-part mindfulness series called Turning Suffering into Compassion and Wisdom. The sessions were on mindfulness of emotions, mindfulness on compassion, transforming habits that no longer serve us. We went over the tool RAIN, which allows participants to recognize, allow, investigate, and nurture their emotions. We have run 6 peer support chat cafes where 45 number of staff participated and benefited from. We plan to continue delivering them throughout the upcoming year.
Okay, so that was our an initiative that we wanted to implement at under our staff capacity, our staff mental health, and that was done. And we will be continuing that over this year and moving on. Under organizational capacity, some of the goals that we had was training, and Kaylee and Sajadev already touched on the number of trainings that have happened, and a large number of CCS staff did attend those trainings. Under policies and protocols and tool development, we wanted to reduce stigma around mental health by integrating I don't know what mental health is, but I know what mental health is. Mental health check-ins in day-to-day settlement work, enhancing existing mental health and wellness needs assessment tools and linking them to OCMS. In terms of what we were able to implement was the training of, obviously that was not our implementation, but we were able to promote those trainings when they came from OCASI, and did encourage a large number of our staff to participate, and which they did, and work in other areas. So a lot of the pieces around creating certain documentation and trainings for staff around crisis response and all of that, that is still to happen, because we did have some turnover in our HR department as well. And now we are currently working with our new HR manager in terms of developing those pieces. And that is work that continues to happen. Last but not the least was the collaboration and coordination. We wanted to build on community collaboration specific to mental health and wellness to fill gaps in services and extend reach to support the wider community. And those advisory committees that we have are just amazing, amazing platforms. I am so fortunate and I feel so grateful to be a part of them. The first advisory committee I came in, I was like, oh, wow, all these other people have so much experience. I don't know if we can do this project. They've already done this for so many years, but these were very, very supportive folks, and a lot of our ideas and how we connected with them later did have quite a bit of impact on the success of our implementation. So out of one of those collaborations I want to mention here is that we, from the advisory group, we did connect with the Access Alliance. And as part of that conversation, which went really, really well, we are now actually doing joint activities with them in terms of Access Alliance. We also have some work that we're continuing to do with Hong Fu. We're also connected with the Scarborough Center for Healthy Communities. So that also is rolling for us very, very well. So here it is. That's our journey, and it continues. And we may not have met all the milestones, but we know how to get there now. We have the knowledge, we have the support from the advisory committee, from Kaylee and Sajade, to be able to get to where we need to get to. And the plan that we have is still there, and we will continue to meet all the other milestones off of it. So thank you.
Thank you so much, Zohra. I'm going to now share my screen again. And hand it over to Sajade.
Thank you, Kaylee, and thank you so much, Zohra. It's wonderful. I learned so much from your presentation, and it's great to see the videos from the youth and the staff sharing their experiences. And I'm really happy to hear about the partnerships that you have established. That's wonderful. So I'm going to share a little bit. We talked about some of the challenges, share some lessons learned, and also share some recommendations from our evaluation consultant. As you know, we have Sonia Narad is the evaluator who has been supporting our work throughout this last several years and sharing lessons learned. So Kaylee, if we can go to the next slide. I'll go through them quickly, and then we will have some time for discussion. How are we doing for time, Kaylee? So if we could stay on the lessons learned slide. Yeah, that'd be great.
Sorry, technical issues. We're okay on time if you want to speak for like the next 5 minutes or so.
Okay, I don't have to rush through it then.
Yeah.
Good. Thanks. So some of the lessons learned, I mentioned previously, leadership commitment and buy-in is huge, and that's been a consistent issue from the beginning. It's been, I think this year has been more challenging, particularly, and I'm sure Zohra can attest to it, in terms of the new challenges. You know, COVID really put a twist on staff issues, staff mental health, and staff burnout, and high turnover across the sector has had a huge impact on not only on service provision, but also on our ability to implement the project. And agencies, even though they are very interested and committed to address the issues, it's been really challenging. And we've experienced staffing changes within OCASI, and that's what Kaylee alluded to it. We were delayed in implementing, recruiting the agencies to work with us because we had our own mental health coordinators both left, and we had to recruit, so it took some time to do that. So that's the main aspect. The other issue is, even though the staff recognize that they have mental health issues and need support. Stigma of mental illness is continuing to be a significant issue. And we heard from our advisory committee and implementing agencies that stigma is preventing staff from utilizing some of the supports like EAP counseling, for instance. They were hesitant to access it because they were concerned. I guess there was lack of trust, maybe, or they're concerned that it might affect their employment if the employer finds out that they have mental health issues. So there's still a lot of work to be done there, even though we continue to provide a lot of capacity building activities. It's so prevalent and not only in the clients, but also for the staff and their mental health. So investing in more support for the staff, that was one of the feedback as well, that it wasn't on the other aspects. Some of them were not participating in EAP and others were saying it's not enough. And I agree, it's not really enough because they fund really limited sessions and they often tend to be more structured. They're not culturally or linguistically accessible. They tend to use, not to undermine CBT, but it's not a sort of for everybody, and it doesn't take into account their actual experiences as service providers because they have personal challenges and challenges of dealing with the client mental health and trauma and vicarious trauma and all the challenges that they are facing in the job. It doesn't really get picked up and captured. So those are some of the challenges that need to be addressed. And that's one of the reasons we decided to implement the staff support groups. That was a new component that we added that wasn't part of the previous pilot sites. Even though like previously we always heard about staff sharing with us how isolated they felt, that the social isolation is significant. They have huge caseloads, they don't have time to interact and support each other, and they felt like they were working in silos, particularly when they were working virtually. They didn't have a lot of opportunities or the time to support each other and connect with each other. So this is why we felt it would be great to adapt the peer support model for the staff to be able to support each other. So I think that's a positive component that we need to continue to explore ways of supporting staff and staff mental health. The other major component, obviously, is working conditions and pay. And that's one of the main reasons why we're losing so many people from the sector. We're not paying them enough. And the workload keeps growing, the challenges keep mounting, and it's a structural issue that really has to be addressed. And there are some initiatives and work that is happening in OCASI and with our member agencies. And it's a conversation that needs to seriously be considered and think about ways that we can have a sustainable sector and support the sector as a whole. In order to be able to support client mental health, we have to support staff mental health in a much more and do much more than what we are doing currently. So next, I will share some of the recommendations. These are just highlights from our evaluation report that I will share with you. So one of the recommendations for OCASI was to extend the time period that we work with the agencies. Initially, our contract or agreement was to provide support for 6 months to work with them to implement the model. And that includes a time period for needs assessment. And it's challenging because the project has many components. It's very comprehensive and there's a lot to be done. Sometimes it could be overwhelming. And we did extend the time period for working with the staff I think we extended it to 8 months maybe. But we need to, and it takes some time to get to know them and do the needs assessment and do the interviews and focus groups. And it's, again, it has many components, doing surveys and things like that. Getting the groups together to do it usually takes a significant amount of time, and then developing work plans and goals based on that. So I think it would be a good idea to extend the timeline for working with them. But also our own capacity is limited. We only have 1 staff, as you see, and I'm quite involved in that. So those are some of the challenges that in terms of implementation. And then the other recommendation is to engage other sister organizations like the Alliance for Healthier Communities, associations that work with community health centers, Ontario health teams, to really look at more systematic ways that we can collaborate together and establish those collaborations. And as Kaylee mentioned, because of the pandemic and because of the pressures, ongoing crisis really that the health system is dealing with, it's really challenging for them to make these kind of partnerships a priority, but at the same time, they have to be a priority because we're addressing these needs of the same population that the newcomer communities, diverse immigrant, refugee, non-status communities, really not getting the supports that they need from the mainstream sector. So how do we address this gap? And today is specifically, I think, the announcement of the federal government working with the provinces, the healthcare transfer agreement. I think this is a really good opportunity, a good time for us to engage in these conversations and do advocacy to see what more can be done to facilitate this kind of collaboration and partnership. It's been an ongoing issue in every knowledge exchange event. I share this, that we have to have more collaboration. And it's been really challenging, and it has to be done at the funder level, at the governmental level. And I'll touch on this again in the recommendations for funders. So next, Kaylee. These are some recommendations for the organizations. Again, emphasizing the leadership commitment. It's not enough to participate in the pilot and do capacity building, put in wellness initiatives. One of the challenges that we've seen over the last couple of years because of COVID, we implement a lot of the capacity building activities and wellness initiatives, but it falls short when we look at developing policies at the organization level and putting them in implementing these policies. Usually that takes time, of course, and it goes much beyond the 6 month. And when we do the work plan with the agencies, we try to get them to do short-term, medium, and long-term plans, and often the policies are one of the long-term things that they put in place. It's not that they don't try to do it, it's just the competing priorities, deciding how are we going to work? Are we working hybrid? Are we going in person? And what are the challenges and staffing issues? And so often, because of these competing priorities, it gets put on the back burner. But hopefully they will return to them and try to implement as much as possible, because I think without that, it's not enough to just train staff on mental health first aid or suicide prevention or those kind of things, when these issues have to be addressed at a systemic organizational level. I think that's, and again, emphasizing with the agencies to try to allow time, invest time in establishing partnerships with local primary care providers and mental health providers wherever possible. We try to do environmental scans, as Kaylee mentioned, see what are possibilities, what's happening at the system level. But it really is up to the agencies and the leadership to take that on and establish partnerships with the local providers. Sometimes it's successful, and again, that's something that takes time. And identify any possibilities where they could be part of the planning tables and voice their opinions and issues and advocate for the people that they work with. And we saw a few examples that Zohra shared with us. Next. And the last set of recommendations is for IRCC funders, other decision makers within the sector, which is very much in line and reinforcing the issues, that the recommendations that I mentioned earlier from a different point of view. That it's wonderful to see that IRCC has been supporting this project over the last several years, and we see some of the recommendations that we've made in the past have been implemented, and there is more investment in supporting agencies. Like I'm looking at previous pilot sites have been able to hire more staff, get more funding to specifically provide on-site mental health programming. And that's the model that we, when we initially started working on this project, part of the review was to look at what are promising practices and promising models of collaboration. And based on our experience of implementing this model over the last several years, the best model is to have on-site support, have on-site staff who are maybe trained in mental health already, having social workers, having partnerships, maybe having the opportunity to have psychiatrists or mental health professionals to be on site, to have a clinic, maybe primary care clinic that is on site to see the clients there, because that's the model that works best. They are, often these agencies are in outlying areas, in suburbs, and most of the services are in downtown, and they're overloaded with wait lists. And because of stigma and because of transportation challenges and many other issues, they're not able to go there to access the services. Virtual services is a whole other challenge for them. And we know that once they establish trust and relationships with the staff in the agencies, they don't want to go anywhere else. They want to access the supports there. So it's really important to have more investment and more support for the agencies to be able to do that. And it's not enough to have one crisis worker or two, it's overwhelming and they burn out within months. So that's not a sustainable model. We need to think about how, this is an opportunity. How can government support these organizations? Because we know I've been in the sector for more than 30 years and I've seen the same issues, same barriers continue to exist, and they are getting worse by the day. Given our current context, and the impact on immigrant refugee communities have been most impacted by the pandemic. And then we see many layers of racism and violence and poverty, and you just accumulate all these additional barriers to it that impact their mental health. So we need to seriously think about how we can, what role can governments and funders play in facilitating these kind of partnerships and making the system more accountable and more responsive to their needs. So I will stop here, and we will open it up to Q&A and conversation, and I look forward to hearing from you. And I see Jonathan here. Jonathan is a manager at the Dixie Bloor Neighborhood Services, which was one of our implementing sites. So Jonathan, feel free to jump in and share any comments from your experience if you would like. We can, as people are thinking about their questions, and you can share your experience as well. Not to put you on the spot.
No, not at all, not at all. Thankfully, I was a part of the process, so thank you for the opportunity. Zohra, always a pleasure. It was a pleasure implementing alongside with you, and listening to all that you had to say. A lot of similar experiences, differences in terms of implementation. You had more fullness in terms of with support, but in terms of some of the difficulties, they were very, very similar in terms of the things that we were dealing with at an organizational level. And then once we got through those and implementing policy and those things, moving forward with the actual action, then we were presented with some difficulties I wasn't expecting to see. Coming from the youth space as a youth worker for almost 10 years, and engaging in that way, I've never encountered the difficulties implementing a program as I did with this. Now, I've also never developed a program straight out of the pandemic, so that presents its own unique challenges as well. But yeah, it just seemed like it was a great opportunity. We had all these great ideas. We had the table where we came together and met and spoke about our experiences. And then, when you go back to the table and you kind of feel like you've teased out one thing, you're met with something else that you hadn't thought of or you didn't think would be a barrier to service, or different things. Just to give an example, working with Kaylee and on the newcomer youth support group, peer support group, things such as the barrier to signing up when we made the flyer, right? And then we had the link to how to register, and then registration wasn't what we thought. So we were like, is internet access a barrier? Like, how can we make this even easier? And then we made a QR code, and it was just going through those different processes and steps was a continuous thing that I would say kept us on our toes. But let me not take too much time away from what you're trying to do. Thank you.
Thank you, Jonathan. And Kaylee, sorry, I thought you were going to talk about next steps. I skipped a couple of slides, so go ahead, and then we can go to questions.
Okay, yeah, that's great. While I do that though, if someone has any other burning questions to respond, because I'll take a second to share my screen, please jump in. Yeah.
Put up your hand if you want to ask a question or put it in the chat.
We did have a lot of answers, mostly providing more support to staff, regular awareness sessions, for example, regular check-ins and feedback, monitor the workload, providing self-care workshops. Someone suggested a social committee that does a lot of activities, fun but supportive. Income increase review is at the center also. Partnerships, more education, more courses, appreciation, more events, partnerships. Those are the main themes. I don't want to read the details, you can see them. But yeah, those are the main themes. Professional development to feel more confident, for example. So this is for the first question. If you can also slide the next one. This one also, how can we increase organizational capacity to integrate mental health promotion? There's more, like, a lot of emphasis on improving the work culture, being involved in HR policies, improving health insurance to cover mental health, providing more support to new staff to gain experience, involving leadership, for example, promoting partnerships with government-funded mental health organizations, more outreach, more partnerships. There were several answers that highlighted outreach and promotion and partnerships with the communities. So yeah, this is also the main themes for the second question. Thank you. I think that's everything.
Thank you, Yazan. Sajida, do you want to go next?
Sure. Okay, so a lot of similar things, providing mental health, mental wellness activities, and providing mental health days if they're not already providing that, encouraging more open group discussions, and giving staff opportunities to discuss stress and having opportunities to vent, and creating supportive and fun environment within the frontline staff with wellness activities. So and some people were sharing that even using games as a way to integrate wellness activity with the staff and providing opportunities to collaborate and have conversations together, pay equity and pay for per task. So additional jobs, and the other one comment that's next to it is also related, stick to the job description, roles and responsibilities rather than keep adding to it. So both of those are referring to the workload and working conditions that impact staff. Some people also share the importance of going for walks, having opportunities for staff to allow them to go out together and interact outside if it's possible on their break, having shared break times, or using potlucks during team meetings as a way to socialize and interact with each other and make things more fun. I'll go to the next question. Give employees a voice, and having, again, there's some overlap between the suggestions with the first question, But I will highlight the ones that are more could be done at the organizational level in terms of hiring more staff, which is getting back to the workload, and so that people don't get overwhelmed with ongoing increases in their work, and implementing mental health policies, developing them, allowing funds for staff wellness, and assigning reasonable workloads. So I'll stop here. I'm mindful of the time to allow others to share as well.
Thanks, Sajideh. Hajim, do you want to go next?
Sure, hold on. Let me just share my screen.
Oh, I'm sharing it. I've got it for you.
Oh, you got it. Okay, amazing. Okay. Phew. All right. Yeah, so I mean, I don't know how to highlight or like coalesce everything, but we have genuine appreciation goes a long way, happy staff equals motivated staff, social activities to encourage team bonding, the resources list, somebody mentioned a live document. The Sophia and Sophia from Durham highlighted the differences between like a smaller city or smaller town and a larger place like Toronto, that they're larger but with limited resources. Amika highlighted that to like kind of address staff burnout, maybe frontline staff or staff who deal with a lot of like heavy stuff, maybe add some variation so it's not constant. So in terms of their workload, like training all staff for mental health first aid, giving the tools and the right language, and less working hours for staff working with clients with high needs. Moving on to the next one, just for time. We didn't get to go too much into detail with this, but we have more education around disability, destigmatizing disability, accountability training for upper management and board members, creating the committees, promoting collaboration between rural and big cities, and roundtables, and flexibility. I saw that in the other board as well, flexibility in funder expectations, leadership, trusting frontline workers to know what is best for them. I agree with that, but yes. You can go next, Kaylee.
Oh, for a second, I thought you had a third slide.
No, I don't know who added that. I thought you added that, but okay.
No, that was a mistake. Okay, I'll just briefly touch on mine. My group had a lot of great ideas. One of the main things that we were talking about was actually around the transition back into the office, and how for a lot of organizations, when we switched to a hybrid model, there was staff were expected to kind of double their workload. So now they were supposed to be offering in-person and virtual services at the same time. So we were discussing how there needs to be some kind of structure or policy in place around how that looks, so we're not overburdening staff, or also maybe looking at having more training. Maybe there's a certain group of staff that are responsible for virtual services and the other staff are only for in-person. And also just like management being supported in their own management being trained so that they can better support staff is a huge component of this. There were a lot of, great ideas around having a shorter work week. A lot of it does come into structural issues. I'm just going to skip to the next question because I'm so aware of the time. Another thing that we were discussing was around, even for managers, like if they're in charge of a bunch of different projects, it's hard for them to be as involved with the staff on the ground. And it also depends on how many staff are even working for one project. Like, is there only one staff per project? So again, a lot of this has to do with workload and what we can do differently to address staff's workload, because it's one thing to implement a lot of wellness initiatives and activities, but it seems like the larger issue is around pay equity and not overburdening staff with their workloads right now. I think I'm going to leave it at that since I'm cognizant of the time, but thank you, everyone. I think that was so great to be able to have the visuals of what everyone created in their groups, and we'd love to share some of that with all of you after today as well. It's nice to have visual summaries of what was discussed in addition to what Carolyn's working on. Yeah, is there any final comments, anything anyone wants to share? I know we're kind of strapped for time, but if there is anything anyone would like to add, feel free to now.
Great, thank you everyone. Have a great lunch and we will see you back at 1 o'clock. Ready to start. Welcome everyone to the second part of our Knowledge Exchange Day. We're very pleased to have all of you back, and it's my pleasure to introduce our speakers for this webinar on trauma and violence-informed care, a primer for the settlement sector. Dr. Nadine Wathen is full professor and Canada Research Chair in Mobilizing Knowledge on Gender-Based Violence in the Arthur Labatt Family School of Nursing at Western University, and Academic Director of the Center for Research on Health Equity and Social Inclusion. Nadine's research examines the health and social service sector response to gender-based violence, interventions to reduce health inequities, and the science of knowledge mobilization. A particular focus is developing person-centered interventions that enhance health equity and take a gender, trauma, and violence-informed approach to providing services for those experiencing violence and marginalization. Dr. Tanaz Javan has a PhD in health information science. Her doctoral dissertation research evaluated the implementation and integration of trauma and violence-informed principles into community-based health and social services in London, Ontario. She is currently part of the Center for Research and Education on Violence Against Women and Children at Western, where she continues to work on the evaluation and implementation of various interventions by applying a trauma and violence-informed lens. Outside of her research, Tanaz teaches psychology at Fanshawe College. She works as a life coach and counselor with people who suffer from depression and anxiety, and facilitates workshops on mindfulness meditation and communication skills. Tanaz is also a skilled painter and the author of the cover art for Healing the Traumatized Self. Welcome to both of you, and we are really looking forward to learn from your knowledge and expertise. So for our participants, our speakers will present and then we will have some Q&A period. So feel free to type your questions in the chat or unmute after the presentations. So I'll hand it over to you, Nadine.
Thank you, Sajde, and thank you everyone for being here this afternoon. It's exciting for me actually to be back to OCASI because I think if I think back to February 2020, this was one of the last in-person talks that I did before COVID. And since then, we've actually done quite a lot of work. And towards the end of this presentation, we'll be able to share many new resources to help you start your TVIC journey, both as an individual provider and also ideally in your teams and organizations. So I'm very excited to be back here and talk about what we've done in the space of TVIC. I'm also really delighted to speak with my friend and colleague Tanaz, who did her PhD with me at Western on this very topic. And, you know, she'll tell you a lot about how to integrate some of these strategies into the settlement sector. So we're delighted to be here and thank you for your attention. So this is what we'd like to do today. And it's nice to have an hour and a half, which will hopefully leave us lots of time for questions. I've been doing many of these webinars and squeezing them into an hour, which becomes sort of 35 minutes after all the pre and post things. So we want to take a bit of time to talk about trauma and its impacts. I think many of you will be very well aware of these things, but I think it's important to set up our framing of trauma and violence and their impacts so that we really understand why the V in trauma and violence informed care is very important and can be quite transformative in terms of your practice with newcomers. We'll go over the principles, and at that point, Tanaz will take over and talk about strategies for the settlement sector based on the research that she's done in this area. And then we'll talk about some of those resources that I just mentioned. Oops. I always start the presentation by talking about the issue of emotional labor and moral distress. And, we did this when we were doing in-person workshops and sessions prior to COVID. And I think things have, in fact, gotten a lot worse during COVID as we experience this collective trauma. And we see many of the social service systems around us really struggling, and therefore the individuals who work in them really struggling in terms of trying to find solutions to support people and also to support themselves and their own well-being. So I do want to acknowledge that, as things have progressed through COVID, but even prior to that, we come into this work with certain values, and we want to do good. We want to help people. We want to support people. And sometimes we see a disconnect between what we're able to do in our organizations and what we would like to do. And that causes what we call emotional labor. And when we see that clients may be poorly served or even harmed by virtue of this mismatch between how we'd like to provide service and what we are able to do, this can be experienced as moral distress. And there are a couple of citations there at the bottom of the screen in case you want more information. And of course, we'll provide our email addresses at the end, and you can follow up with us. This is a common feeling. So I guess one of my points here is you're not alone, but it's also hard to talk about these issues, especially when we're thinking about past and ongoing violence in the lives of those we serve and also in our own lives, and how we as a collective society, but also as individuals, may be contributing to this. It can be upsetting and distressing. So I acknowledge that. Please take breaks if you need to, step away and so on, follow up, as I said, but also embrace some of that disruption, as we've written in some of our work. Until we disrupt things the way that they're currently done, we won't be able to change. So unless, if nothing changes, nothing changes. So please embrace the disruption to the extent that you can while keeping yourself safe. So what do we mean by being trauma informed? Well, trauma, as many of you will know, is the experience of and response to a negative event or events that threatens a person's safety, life, or integrity. And really, it's beyond everyday stresses because it overwhelms people's ability to cope. And this is when we get into the space of post-traumatic stress syndromes or symptoms, and understanding that when we are under this sort of threat, these responses are anticipated. Okay, they might not happen to everyone, but you can certainly anticipate that they will happen to people, and they might not happen every single time to a person, but they are something that we should anticipate and understand, because as I will talk about in a moment, these are physiological mechanisms that help us cope with these sorts of threats. So there are different forms of trauma and traumatic stress. They can be acute, resulting from single episodes or events, or complex and chronic. And of course, people can experience one or more events in their lives, acute and or chronic. So we also have to keep in mind the complexity of the interactions of these sorts of experiences. And what we really try to do when we talk about trauma-informed approaches is understand what trauma might look like in a service interaction, because a key goal of trauma and violence-informed approaches is to shift from judgment and not wanting to interact with people who are behaving a certain way to understanding and compassion and respect. Whether or not people are exhibiting fight, flight, freeze, or fawn, we want to understand that these responses are anticipated or anticipatable, and we want to be able to address that and deal with it in that interaction to make people feel safe and to provide the best possible service. And I think an important point too is what this does look like within and between groups and people will differ. And there are sort of different factors that might influence how people present when they're in an activated trauma state. And certainly Tanis will know a lot about this as well from her graduate work. So trauma is extremely common. And this is a map from the Global Mental Health Survey, which did not include Canada. So we added some data from a Canadian survey. Canada would be in the red zone. So this is basically saying that over 70% of your population in Canada, 76% of adults would have experienced trauma that would meet the threshold for post-traumatic stress. So it is extremely common. And the important point here is, given that it's so common, either as a direct experience or the experience of those within your immediate circles, we should treat people as if they have experienced trauma without needing to know exactly what traumas they have experienced. So this is the notion of a universal approach or a trauma-informed approach. there's some statistics here. I was actually updating myself this morning on the rates of trauma from those who are coming from war zones, who are coming from places where serious accidents and natural disasters have happened. And for example, in the Middle East, very, very high rates of trauma among children and adults, with up to a third or more actually having been diagnosed with post-traumatic stress disorder. So, the people whom you're serving, who have come to Canada often through very difficult paths, will have likely experienced multiple severe forms of trauma. And it's probably not a bad idea to assume that we need a really strong trauma and violence informed approach to their service. And these are some examples of traumatic experiences. So on the left here, we've got, interpersonal forms of trauma, and then situational forms of trauma. And then at the bottom, the notion of collective forms of trauma. I've already mentioned our common experience of COVID and the particularly ineffective responses to COVID in some cases as a collective form of trauma. But I also want to recognize that the ongoing colonial impacts of things like residential schools on Indigenous people in Canada has also been a collective form of trauma that is ongoing, as well as historical. I recently gave a similar presentation in Kigali, Rwanda, where it's been about 28 and almost 29 years since the genocide against the Tutsi people. And again, that is a major collective form of trauma that has affected an entire country. And I think we have a lot actually to learn from people who have gone through that experience. So the little graphic on the right is just to sort of show that these forms of trauma are complex and interrelated. For example, if you're coming through a refugee camp experience or a government-assisted experience, you are probably coming from a highly traumatizing situation in your home country. You may be in a refugee camp, and then you're going through a process that is itself onerous and can be quite disrespectful in the process of actually coming to a new country. So we see these sort of interaction of situational, interpersonal, and collective violence and trauma as impacting people, and the exposure to certain forms of trauma might be increased because of experiences of other forms of trauma. So it is complex in terms of people's lifelong experiences of trauma. And I think that's one thing we sort of need to take into account in that moment of interaction with somebody and as we're developing programs and services for them. And as I mentioned before, the trauma responses and traumatic stress is a physiological response to protecting yourself from danger, from imminent harm. And, basically, I'm not a neuroscientist, but, at a high level, I can say that as you are having a traumatic response, either in the immediate moment of a trauma, or if reliving a trauma, if re-traumatized by something in the environment, basically you move into survival mode. So your higher order thinking sort of shuts down and you, become, they call it sort of brainstem driven, where parts of your brain are releasing hormones to help you protect yourself. So that rush of adrenaline that you might feel, and your brain becomes sort of bathed in cortisol. So you are trying to make sure that you're safe in that moment. And again, what that looks like might be different from one person to the next. Some will get aggressive and want to fight their way out. Others will shut down and just want to, protect themselves that way. Others will flee, so on and so forth. So that physiological response will be different and will sort of drive what that interaction might look like. And the response is actually itself complex and based on a number of different factors. And there is increasing research showing the genetic and epigenetic impacts of trauma on the brain and the body. And that, ongoing exposure to, for example, complex and chronic forms of trauma actually can change the way that your genes are expressed. So changes in the DNA and changes in the physiology based on your genetics. And on the right here, you see a little graphic, and at the bottom, a YouTube link to a nice video that one of my colleagues did from our Prevail Research Network that talks about, the interaction of, in this case, adverse childhood experiences and, how it can change your brain and body and behavior. So that's a nice video if you've got time to visit it, and we will be sharing the slides afterwards, so you'll have that URL. So there are sort of the physiological pieces, and these are also related to when the trauma might happen and how severe the trauma is. and how chronic, as I mentioned, it might be. So the earlier in life these things happen, the more severe they can be. And I just want to pause for a moment and say, many people survive and thrive when experiencing even very severe forms of trauma. So this is not sort of, a blueprint for everyone, how they will respond to trauma. And towards the bottom of this list, you see things like community factors and social factors that might improve resilience and be protective in terms of these trauma responses. So I think that sort of, as we move away from the individual to thinking about their community and our broader society, we can think about ways to protect people and to help them survive and thrive, and to do that in a collective way rather than leaving it to individuals to try to heal themselves. So we do want to look now at more structural factors and how those things can be protective. And we do know from a lot of research that trauma and violence and experiences of those things will increase the risk of poor health. So there's a whole list of health issues here. I want to actually focus on a couple of things, because I think this is where we get into some of the judgments and issues that many people have when seeking services, when they've experienced forms of trauma that lead them, for example, to use substances. And I think on my next slide is, yes, this complex graphic. I don't have time to go through all of this, but I will say that we have a new e-module, an e-learning module that would be freely available on our Equipped Healthcare website that talks exactly about this. This intersection between experiences of trauma and violence, and how they are very related to chronic pain, and how chronic pain is related to substance use, and how trauma and violence themselves are related to substance use. And then the sort of broader complexity of this is the substances themselves. So some substances are quite stigmatized. For example, the use of street drugs is a very stigmatized behavior. Other substances among certain groups of people are not stigmatized. Well-off people using alcohol is not a stigmatized activity. However, other people using alcohol, for example, Indigenous people, if using alcohol, are treated very poorly in healthcare systems, for example. So this gets quite complex. We've got complexities around the types and interrelationships of trauma and violence experiences, and then the types and interrelationships of the consequences of those experiences, and then how people are trying to cope with those experiences. So this, I present this because in work we've done evaluating the effectiveness of our workshops, this becomes one of the big takeaways when people start to understand that those traumatic experiences are really related to pain, and then substances are being used to help deal with that pain. And it's physical and emotional pain, and cultural pain, quite frankly, spiritual pain, if you will. You can switch your judgment about people's substance use into compassion and trying to understand maybe what you would do if you were in their shoes and experiencing that sort of pain. And to add to the complexity, I mentioned sort of race is another factor in this in terms of how people's substance use is perceived. Gender is a big issue as well. Women are more likely to report, issues of chronic pain. And that is often dismissed in healthcare. Men might be experiencing chronic pain, but because of gender norms, are actually feel they can't, talk about that or seek help for that. So gender is another piece of this, and that gets into the complexity of these intersectional lenses. So I'm hoping that makes a bit of sense. And as I say, we've got resources to help people delve into this a little bit more and think about this complexity. And of course, we also want to mention, I mentioned moral distress and emotional labor among providers, but we also have, the very real phenomenon of vicarious trauma. And as many of you will, you're hearing extremely difficult stories of people having very bad experiences in their home countries, in their transition to Canada, and then once they arrive here. And hearing those traumas and reliving those traumas with people itself is traumatic. So again, vicarious trauma, that exposure to other people's trauma and the effects that it starts to have on you as a provider, is an anticipated response. And in fact, would we be human if we didn't have that level of concern and compassion, which eventually becomes, almost like a feeling of burnout, like I cannot hear this anymore. It is affecting my home life. I work a lot in the area of gender-based violence with those who serve women experiencing domestic violence, And that trauma comes home with them. Those stories come home with them, and it's extremely difficult sometimes to get through that. So the symptoms of vicarious trauma can often mimic the primary symptoms that I talked about before of primary stress. So fight, flight, freeze, and fawn. And this will again vary depending on the individual and the protective factors that are wrapped around them or not. So a couple of important distinctions. When we talk about trauma and violence informed care, which I'll sort of get to in a moment, we really want to distinguish it from trauma specific care or trauma specific services. Those are specialized services by trained practitioners who are delivering essentially trauma treatment. We are not advocating that everybody needs to become a specialized trauma treatment expert. That is not really what a trauma informed or trauma and violence informed approach is about. Trauma-informed care, which is sort of what I've gone through up to this point, is, as I've mentioned, a universal approach where you understand that the prevalence and impacts of trauma are such that we really need to treat everyone as if they've experienced trauma and make sure that our services are safe and not re-traumatizing for people who are in our care. One of the issues that we have, a concern we've had with the notion of TIC or TIP, trauma-informed practice, is that it tends to focus very much on the individual and situate the trauma and its impacts in the minds of individuals instead of the broader social circumstances that I've started to allude to. So what we've done is really tried to emphasize the V. So as a summary, being trauma informed really means recognizing that traumatic stress is common and will affect what you see in a care interaction. It affects how people think, how people talk about their health, how they behave, and how they feel. And I've mentioned fight, flight, freeze, and fawn. I've also emphasized the issue of the behaviors around substance misuse. And in fact, right now we're working with some physicians at the University of Toronto around a learning module for physicians around lung cancer screening and how to talk about smoking in a way that's trauma and violence informed to promote uptake of cancer screening in groups that might have felt very stigmatized around their smoking. Oops. So now we're going to add the V and really start to focus on what we mean by this V. And I sort of allude to the fact that there's a smaller V and then a bigger V. And, this is not small in any way, but it's sort of a good way for me to keep track of things. So the smaller V is really focusing on interpersonal violence as a unique form of trauma. As I've mentioned, the earlier these sorts of traumas happen in someone's life, the more impactful they can be across the lifespan. And forms of trauma such as child abuse or later on in life, dating violence or intimate partner violence are different because they really are an abuse of trust. So people will have their ability to form meaningful and deep relationships and attachments impacted by these violations of trust in these relationships. And that can persist across the lifespan and in fact become intergenerational. So we do know from research in the area of intimate partner violence, if children are growing up in a home where there's violence between their parents or among their caregivers, they are more likely themselves to grow up to both use violence and or be survivors or victims of violence. So that, you live what you learn and you sort of start to see these patterns intergenerationally. And really safety in these cases becomes paramount. And if you think back to what's going on in your body and your brain, that trauma response remains activated. So those hormones don't come back to a resting level. You are always in that vigilant mode because this trauma has been ongoing for a long time and its responses to it have been ongoing for a long time. So when you're interacting with people who've experienced these forms of interpersonal violence, it's very important to keep that in mind. And again, I started to mention the issue of gender a little bit before. I'm a gender-based violence researcher, so to me, everything is gendered, but it's gendered in multiple ways. For example, we know that women are more likely to experience intimate partner violence and it has more severe impacts for women. But we also know that men experience interpersonal violence outside of intimate relationships at higher rates than do women. People who do not identify as men or women or who are transitioning are far more likely to experience intimate partner violence and other forms of violence. So gender plays a big role in this. And also our societal response and the norms we have around who gets help, who gets to seek help, and so on is important. So I mentioned that, men might not feel that they can seek help when they're having, effects of trauma because of masculine gender norms. So what we see, in fact, is higher rates of deaths by suicide and problematic substance use and overdose among men. And that is a way that our society has constrained men's choices around seeking help, such that they are using more violence and having these consequences that often lead to death. So those are some of the gender dynamics in all of this, and they intersect with other forms of identity and circumstance. So I've got at the bottom here, income, disability status, Indigenous status, race, and so on. And that's where we get into this issue of structural violence. I often pause here also to just note that as providers, as human beings, we come with our own beliefs and sometimes biases. And many of these can be hidden beneath the surface or implicit. And this field of implicit bias is very well studied by my friend and colleague, Dr. Javid Zakara. And we can provide links to resources. Certainly there are lots in our curricula. But that these biases might be beneath the surface for us. And really the hard work as we start thinking about becoming trauma and violence informed is to try to examine those things within ourselves and make sure that they're not a barrier to us providing care. I mentioned substance use and substance use stigma, which is a very pernicious form of stigma, and definitely impacts people's trajectories of care. Many people will not even seek care because they know they will be stigmatized and treated poorly in health and social services. But even if you're doing your best, and I've got this sort of middle bullet, that work that Javid has done, healthcare providers are often very wary of interacting with people who are having severe mental health issues because they just see them as unfixable. And if they come to an emergency department, which is really designed for sort of trauma medicine, it's difficult for them to sort of find the fit between the care that they're comfortable providing and somebody who's having an acute mental health or substance use crisis. And they might see these people as unfixable or difficult, even worse, or non-compliant, and those sorts of stigmatizing labels. So they avoid those patients. And from the point of view of that service user, that avoidance is seen as stigmatizing and as a form of discrimination. And I've also heard, people talk about, for example, as we do more and more, anti-oppression and anti-racism training, people aren't sure what to say. So they'll say, I had an Indigenous client, but I just didn't want to say the wrong thing, so I didn't say anything. And, that might seem like a good option for you, but from the point of view of that person, you're avoiding interacting with them. And again, that can be experienced as stigma and discrimination. So we have to think about those things and how those biases might be impacting our ability to provide good, safe, respectful care for people. And then we get into these broader issues of structural violence. And in the blue bubbles here, you'll certainly see, I think, many of the factors that will be impacting the people that you're serving. Barriers to finding safe and affordable housing once people arrive in Canada, integrating into communities, especially if there are ongoing, is the ongoing racism, ableism, structural poverty, rates of income support from government that are really insufficient to support people's, well-being, especially as we see inflation rise and so on and so forth. So these are, this is getting at the bigger V, that these forms of violence are choices that we make as a society. They are often embedded in policies and practices, and they harm people, which is why we call them structural forms of violence. So we decide collectively as a society and through, our voting, what our minimum wage will be, for example. And if minimum wage is not sufficient to actually pay the bills for people, then we have structural poverty. We have poverty that is embedded into the way that we've decided to organize society, and more people will be living in poverty. And then poverty comes with its own set of stigma, its own barriers to care, and so on. So complexity upon complexity upon complexity, I'm afraid, but I'm happy to say that some of the work that we've developed around TVIC simplifies things for you a little bit. So TVIC and bringing in that V really is about that critical understanding of these more complex forms of trauma, especially interpersonal forms of violence, and how we as providers are the first line of intervention with people, and the way that we act actually makes a difference. And I think that's a really important takeaway as we look at these sort of big, complex social problems. You might say, well, what can I do? I don't know what to do. Well, what you can do is apply some of the strategies that Tanis will walk you through to make sure that you as the care provider are doing things to make that person feel safe and welcome and cared for. So that's when we get into that humility and cultural safety. So you as a provider have power. You need to use that power with those that you are serving, not hold it over those you're serving. And the notion of cultural safety really is about creating a culture of safety, not necessarily learning how people, celebrate things or what foods they eat, but, making sure that regardless of people's background, they feel safe in your organization and in your care. And this includes understanding, obviously, those impacts of structural violence and people's journeys to where they are today. So TVIC, in summary, really extends that notion of trauma-informed practice to those broader social conditions, that notion of structural violence, and also attention to systemic and institutional violence, including what we as providers might bring in terms of implicit biases. So understanding that those practices might be baked into our protocols, our intake practices, the way that we set up our waiting room, the way that we put people on hold, all of those things in an organization might be experienced as harmful by people, and therefore they are violent. And it brings into perspective that broader piece around historical and ongoing violence, including collective violence that particular groups have and continue to experience. And then the real focus on making sure your providers are well and having a really healthy organization that has a culture of safety. I've made the point about substance use and anticipating certain responses to highly threatening events and ongoing impacts and pain, and really making that shift from what's wrong in the person's head to what's happened and is still happening in their life. That is really, again, one of the major takeaways, to really take people to understand they're in a broader context. And often when you're interacting with them, we often say this to people, for example, in an emergency department, when people come to emergency, they're not having their best day. So, if you can get a little compassion and empathy and see how you might feel in that situation and walk in their shoes, that might help you sort of overcome some of the frustration that you might feel when people are not behaving in ways that you're finding easy to deal with. And as I mentioned, again, really thinking about those complex forms of trauma and lifelong trajectories of exposure to violence. So we have 4 principles, all of that sort of, really distilled down to 4 highly tailorable principles. I've mentioned, I did a presentation like this in Rwanda. We've worked with different types of services. Tanis has done work with police services, obviously with the settlement sector, different kinds of health services. I've done a recent series of webinars with financial literacy educators to make their education practices more trauma and violence informed, with family services. So these are tried and true, and if we approach them the right way, they're quite impactful in terms of changing people's practice and supporting organizations to be trauma and violence informed. So those are the 4 principles. I've really tried to emphasize that we have to focus on those structural and systemic factors and actively counter forms of oppression, especially racism, discrimination, gender bias, stigma, that sort of thing. And so now what we're going to do is Tanis will walk us through what these principles look like in settlement services. So I think at this point, I turn it over to you, Tanis, and you just tell me when you want me to advance the slide.
Sure. Thank you so much, Nadine. Thank you so much, Sajida, for the introduction. And also, Nadine, it's a privilege to be here. I also see lots of Persian names, so I'm also Iranian Canadian, so it's not lovely to see people coming to this session from all different backgrounds. So it's a privilege for me to be here. I would love to always talk about this and share my passion that I've been lucky to be able to translate it into research and teaching and working with people. What I learned here and what I'm sharing with you, it wouldn't be possible for me to bring it to you if it weren't for the generous participation of organizations who decided to share their knowledge and insight with me. And also through the work that I've done with Nadine, being her student has been very impactful for me to become who I am as a researcher, as a teacher, as a human being. So it's always a privilege to come and to present this with you, Nadine. Thank you so much. So if we can go to the next slide. And then one more click, so it's going to show me. Yeah. Okay. So the other way that I would like to also get you to think about TVIC and the principles of TVIC is this notion of CPR, so bringing that vitality back to the organization. So often when we get to talk to organization and we are invited to give them training on TVIC, they're at the point of, I don't know what else to do. There are all these problems and we need to do something about it, and we don't know how to approach from here. So TVIC is, recognizes that collective effort. So it's not, it encourages to move from that individualistic approach to solving problems to more a form of collective care that brings that compassion, that understanding in the equation of finding strategies that could be helpful for the organizations and providers and their clients by creating connection, considering what is happening in the organization and how we can work together basically to enhance the services that we provide and enhance the experience for our clients. But next you see that also, Nadine, if you just bring the next one, thank you. As Nadine mentioned, this is going to create some disruption, and that's okay. It's a part of that. Creating the safe environment starts from the beginning, how we create a safe environment to being uncomfortable and with, together, and look at the power dynamic, how we have those pressure points that are causing a problem, and sometimes that pressure point could be, because of that pressure point, could be policy in the organization, sometimes it could how we provide service, and how can we identify that. And finally, the R stands for the reflection. How can we reflect on the experiences we had, how we can create new relationships that are relevant. Sometimes we come up with strategies that they may sound interesting and helpful, but when we want to apply those strategies, they may not be as relevant as we want them to be, and how we react. How can we be more proactive in our reactions and again enhance the services in the organization. So the next slide, please. I'm going to break down the principles of TVIC for you. Nadine just went through them. So we're just going to bring them to the practice, and we're going to do that in both organizational level and provider level. Again, the intention behind TVIC is very much about collective work, and it's not, again, another checkbox that you need to check or another thing being added to the, I'm sure the very busy schedules and that you already have. So it's more stepping out of that busy, and chaotic environment sometimes, and rethinking about how we can change, our organizations, change ourselves both on the organizational level and individual level. So we start with understanding trauma and violence and its impact on people, whether that's the providers or the clients. We need to make attention that they are both important. So when we talk about TVIC, we recognize the impact of vicarious trauma also, but how does that could translate into policies that we develop in our organizations? How can we change the culture of the organization in a way that it's mindful of the impact of violence and trauma, and how can we provide trainings for our staff to learn about it, and how that can change their practice, and how in combination of changing the policies and changing the bringing new training for our staff, how our service provision could be different, and what does it mean to have that trauma and violence awareness embedded into our organizations. So when I talk about each of these different principles, sometimes I have examples coming directly from my research that I also share those examples with you. So on the provider level, that increased knowledge of about trauma and violence could look like, again, as Nadine mentioned, that how those challenging behaviors could surface in our interaction with clients. Again, that difficult patient is difficult clients is a very good example. I also talk in Fanshawe with my colleagues about how we can bring that lens of trauma and violence informed principles into teaching students and in our classroom. And it's the same is that difficult students, and that's the we often, when we talk about trauma and violence, it makes so much sense, but personally, even for me, being so much involved in this work, there are moments that I need to step back and say, okay, I can hear myself saying what is wrong with this person and changing that into what's happened to this person. And sometimes it's not easy to do. It could be, for me, it's that student that may send 7 emails in a row complaining about something, and and how do I bring that awareness? How can I believe their experience? How can I affirm and validate what they are telling me? It's very easy sometimes to doubt what people are saying, but I often think if somebody is taking their time to write 7 emails to me to talk about what they are going through, that means that I need to believe them. And that could be, your line of work is that client that needs more attention, that they need assurance, they need to be seen. It is very important to also recognize their strength. How do we look at them? The concept of resilience is very also important. So how can we recognize their strength they bring, but also how can we express our concern and show them that we do really care? So the next slide, I have an example for you from a settlement worker who worked in one of the agencies, and I talked to this person after the training, and this is what this person had to say. I believe that is an important part of the work that we do, especially because of the profile of the people that we work with. So again, we often, in the settlement agencies, we work with people who come from a very traumatic and violent background. Sometimes it's an ongoing, as many of you know, for instance, about the tremendous difficulties people feel and encounter nowadays in Middle East, whether that's in Iran with the protest and everything that is going on, the brutality that comes from the government, the very recent earthquakes both in Syria and Turkey. So it's not that the trauma and violence has often been something that happened in the past for these people. It is an ongoing, and even for us being here, how do we get triggered when it comes to hearing this news and bringing that with us to our work and in our life? So we provide services that are that we likely need those tools, or we need that information. Again, bringing TVIC instead of a burden that I have to now take care of my clients, looking at it as a tool. How can this help me to understand what is happening in the room with my clients or in the organization? What might be the trigger for people, or how do you identify trauma? I really find that part important. So then next slide, please. Then we the way that I like to think about TVIC is, okay, now I have the knowledge, I have that understanding, and that's, an understanding not only on the individual level, but the organizational level. And we know one of the most important healing factors when it comes to trauma and violence is creating safety. You know, trauma is all about losing that ability to feel safe, whether it's with the parents, whether it's a caregiver, whether it's a country. It is always that same feeling of safety that's been taken away. And therefore, it is a very important factor to recognize that how we can create safety. One of the very interesting practices that we can do is what we call trauma walkthrough, meaning that you know, if you put yourself into the shoe of a client who comes to the organization, and if you can think about the different, you know, trauma responses they may have, how the environment, the physical environment even of the organization is or is not equipped to provide that safety, and what kind of inputs, you know, you can get from your clients, what kind of things that could be helpful. I remember when I got here and the first time that I stepped into a settlement agency, the fact that there was this Farsi word of, you know, saying welcome or saying hi in my language immediately created that sense of safety for me, and feeling that I'm seen, I belong here. So sometimes it's not, you know, a very you have to take like very important or significant steps to create that safety. Sometimes simple things such as welcoming people when they come, providing, you know, coffee and tea, providing the space that, you know, there are toys, for instance, for the kids to play. It would be a very, you know, simple way of to provide that safety for people who come. And again, how can we create that safety for our staff? You know, what kind of things we have, if we expect our staff to have confidential, you know, conversation with the clients, do they have that space that they can feel safe in order to provide that kind of conversation? And how can we also support our staff at risk of vicarious trauma? Many organizations, when we work with them, even though it's, you know, they can benefit a lot from having, for instance, a psychologist on the side, but that peer support is very, very also helpful. The learning how to debrief, you know, we don't want to burden our colleagues. We don't want to, you know, put more pressure on them going through difficulties that we also encounter. So there are tools to learn how to debrief and how we can, you know, provide that safe space for ourselves and for our colleagues also. And then safety protocols, what kind of protocols we can put in place organizationally that again makes it safe, makes our organization look like a more safe place. For instance, you know, you may work in an organization that is located in part of the city that may not feel very safe for the clients, especially coming if they experience, you know, all sort of different form of violence, you know, sexual assaults, for instance. It could be very triggering for them if you set the appointment later in the evening when you know, when it's getting darker. So, you know, little things like that could be really helpful. Or if you have your clients in your office, you know, the fact that if they sit in a way that their back is toward the door may create an unsafe environment because they don't know what is happening, you know, behind them. They don't know if they can run away from a situation and they feel uncomfortable. So again, these are little strategies that trauma walkthrough could be very helpful to think about how we can change the organization in a way that creates that safe place for everyone. Next slide. So this is another example. When clients walk into the agency, what do they see? Is it accessible? Is it welcoming? These are the questions that we can ask. People think that like we are too cramped. Clients come in, there is no confidentiality, you know, like it's not welcoming. Now we have dedicated staff areas. So things that they change after learning about trauma and violence informed principles. We are going to have sort of partitions in like little cubicles that still, you know, we are together. So we
I think Tanaz just froze. Tanaz, you just froze. I'm not sure if you want to turn off your.
So if we go to the next slide. So as we were talking about that, creating that emotionally safe space. So how does this is going to look like on the provider level? Again, having that awareness of the impact of our power dynamic. This is also very important to think about it, what kind of power dynamic I have with my client. What is it? What kind of background they come from? So often we have clients that they come from or a culture that is very difficult for them to question authority. And if they find themselves in a situation that they feel that we have the authority, the provider has the authority, they may have a difficult time to question that and basically voice their concern. Again, how can I bring that non-judgmental approach to people? Sometimes it's difficult, especially if I also come from a traumatic background. How can I find myself in a situation that I'm not judgmental? I can understand. Again, I believe that experience. And sometimes it is providing that safe space again is as easy as explaining what they need to expect, or how this is going to unfold, what are the process are going to involve, and how we can move from there and come together basically to find a safe space that's going to work for a provider and the clients both. And again, what safety means for my client. How can I basically bring that safety to the relationship? Again, questioning what kind of approach I have and what kind of impact I have on the relationship. And then next, you can see another example if you move to the next one. Thank you. So for instance, this was a very interesting example that I learned a lot from this one, talking about the housing issue. So for instance, when it comes to housing, it's getting really challenging to find apartments and houses for our clients to live in, right? Especially for a large family, it's very hard. Sometimes clients come back and say they feel like they are being forced to take this unit, that they did not really like it because they want to live closer to their relatives. Again, it may be very difficult to be engaged in that conversation with the housing issues. For instance, we have, it might be very difficult for you to find a proper housing for someone who comes from, for instance, the refugee camps, and we may think that they have to be actually quote unquote grateful to be here, and now they have a safe space to live in, but they may not accept that because they want to be close to their family. So that it may, if I don't have that background learning about trauma and how that being with your family creates a safety for these people, I may think that okay, this client is very ungrateful or entitled, so but that this person, this settlement worker was talking about how learning about the trauma and violence changed that dynamic for this person, and started to recognize actually why this is the need for the client, why they want to be with their family, and what kind of emotional safety this can create for them. So continuing, this obviously has an effect on emotional well-being of the clients. There's like this kind of balance you have to go through when you are providing these services, that client do not feel like they are being forced into taking an option that they do not really want. Again, recognizing that power dynamic and how we can bring that to our practice. And next slide, please. Okay, so we learned about trauma. We are trying to create a safe environment. How are we going to connect? How are we going to work together in that safe environment? And this is what the third principle is about. So how can we have policies and processes that allows that flexibility? For instance, one of the things that I heard in they changed their organizational policy to basically foster opportunities for choice was this organization provided free showers for people who suffered from homelessness. And then that organization was not providing the service after 4 o'clock or before 9 o'clock. And the buses around the organization would arrive either sometimes, especially in the afternoon after, or very early in the morning. And the client sometimes had to wait in cold weathers, for hours to be able to enter the organization, or they were too late. So one of the easiest things that they did was I say easy, I recognize sometimes not that easy, but they changed the operational hours for providing the free shower for these people. So opening up half an hour earlier or closing half an hour later provided a chance for many of these clients to be able to use this free service. And again, involving staff and clients in identifying, what is it that my clients need? What sometimes we provide trainings, different strategies for our service providers, especially without knowing that really if this is really going to help them. So on the next slide, actually, I have an example of this, talking about we keep on brushing against the structural pieces. So, it's hard sometimes to do self-care training, but then our staff don't have time for breaks. It's one of the best examples I can come up with from an operational perspective. I often think like scheduling problems, sorry, policy pieces, things like that. So again, talking about, for instance, bringing mindfulness, trainings, which I can relate to. It's a helpful practice, but if I, invite people to do 15 minutes of mindfulness meditation during their break, and they don't have time to break, they are eating their lunch as they are, continuing their work, that becomes irrelevant unless the organization recognizes that and provides space for something like that to become relevant and a practice that actually can help. Again, with debriefing, the same. If we expect, people, you teach them that debriefing is an important way of unloading that vicarious trauma and talking to one another, do we provide that space for our staff to do that? Code continues. I often think like scheduling problems or, policy pieces, things like that. Unless those things change, it's hard for our staff, I think, at the individual level to really make sustainable changes you want, not just the individual level pieces. Again, as we keep emphasizing it, this approach is very much mindful of the interaction between the organization and individuals and how they go hand in hand, and we need to take care of both in order to provide trauma and violence informed care. And again, this fostering opportunity for choice and collaboration and connection. When it comes to the provider, comes to that non-judgmental approach to responses, again, being mindful of, for instance, sometimes experience of trauma and PTSD could look like lack of attention and lack of affect. So people with PTSD often have difficulty to feel their feelings, and that may come across as lack of connection. So, but if I have that knowledge, how do I reinterpret my interaction with this client, and how can I have realistic options and choices? Another example, for instance, would be when the Yazidi women came here, especially we had many of them in London. How do we, for maybe providing, counseling for this population was not the best options, even though it was coming from, a compassionate place to provide service for these women. But the problem is sometimes that if you come from a collective culture, if you have experienced violence and trauma, you may not feel actually safe to sit in a room and talk to a stranger who feel, at the moment could feel that completely disconnected from your reality. So therefore, considering their choices collaboratively, inviting the clients to voice their concern and basically provide that their insight about what kind of choices would be helpful for them. So on the next slide, I have a quote from another organization that I would provide translator and interpreters for different population in the community, and they were talking about how in understanding the principles of TVIC has helped them to change their practice. We always tell interpreters that they have to understand and digest the idea that in that room they are the only person that understands absolutely everything happening. Again, going back to that power dynamic, how I may be in a position of abuse if I'm not careful with my place here, right? We always want the interpreters to be quite aware and realize their role, singularity, and importance. So again, it was also what I remember from this conversation, just to add to the piece I have here, that understanding trauma and violence and the impact of it in our body and our mind help these interpreters to not interpret the symptoms of experiencing trauma, exposure to trauma and violence as weaknesses. Sometimes we think, we have to push through things, or if I say I don't want to work with this client, or if I cannot do this, it's a sign of weakness. Whereas when you are exposed to these stories over and over, you may get to the point that it becomes too overwhelming and you need to take care of yourself if you know about vicarious trauma. Again, in that room, when I'm providing that service for my clients, if I look at trauma responses as a sign of weakness, how that's going to impact my interpretation for that person, where I am the only person who is aware of what is happening in that room. And finally, the last principle, we talk about user strength-based and capacity building approach to support clients. And this comes, I saw that actually in the comments, we talked about resiliency, and this is the point that we also recognize the resiliency. But on the organizational level, for instance, if I expect my staff to have that meaningful relationship with their clients, do they have enough time? Do they have programs available to them to offer to clients to have different services? Right now, actually, I'm working with emergency department, looking at how can we bring those more resources available, for instance, for the indigenous patients, to have that entering that healing center, talking to someone who comes from that background. So that's something that the organization needs to put in place in order to help their providers to provide that. And, again, ongoing opportunities for learning more, giving staff that the tools they may need in order to move forward in their practices. And on the next slide, on the provider level, we are looking at listening to validate. Again, there is so much power in that, mindful listening, attentive listening. I'm sure many of you are already practice that. This is just our way of sort of bringing everything together and organize it under this principle. So I'm sure many of you know how, providing that space by listening can, give people this to rely on their strength. And how can we recognize that, right? So if you have a client who just arrived in Canada, it's been like a couple of months they are here and they manage actually to take the bus and come to the organization, it takes lots of strength to do that. And how we can recognize that by just saying, it's great that you are here. I'm very happy you're here. So it could, you know, it can move from the approach of, oh, my client is late, I have another client coming, you know, and they don't really care about my service here, to the point that all these people just arrive. So it's hard for them to navigate the city. And, you know, even though it's frustrating to wait for someone, but how can we acknowledge that, you know, they are trying their best. And again, that would be added to the organizational piece of having enough time to wait for the client, for instance, to show up. And how can we teach them different skills? You know, sometimes it's just, you know, that grounding techniques, you know, when their clients come and they're very stressed out, maybe just give them some time, you know, to drink a glass of water, to ground themselves, take a couple of deep breaths, and, you know, helping them to be able to start listening, for instance, engaging. So the last example I have for you, we've also had a lot of feedback that our client really like a lot of the virtual service at this point. So actually this code is from post-COVID, when the organization decided to have some of the appointments in a virtual space, and providing that opportunity for clients. We are centrally located, but we are not in different parts of the city. The code continues. So it really changes, and it does make it more accessible, that they don't have to travel from other parts of the town. They can access services, so they don't have to get on a bus, drag their kids on the bus, or pay for the tickets, or all these different things. Again, you know, I really love, you know, to bring this insight into our conversation about how we may have assumptions, you know, that something could work or not work. And when we actually talk to the client, you know, you may feel like, oh, virtually visiting with people may not, you know, bring that connection to the conversation. But if actually helps the client to, you know, to don't spend money on the bus tickets, having somebody watch their kids while they're at home, and, you know, engaging in the conversation with us, getting that feedback from the client may actually change how we feel about that interaction, right? So it's again important to be mindful of, we may not know what is the, you know, even though that's the intention, what is the best option for our clients, and, you know, inviting them to also participate in decision making. So on the last slide, so again, just thinking about the concepts that I started my talk with, you know, having that CPR, you know, the C stands for that collective care. Again, this is how can we bring that intention into our work and into our organization on any level that we are involved in, to provide that collective care, which is inclusive. It does recognize the staff, but it does also recognize the clients. How we take care of the disturbances or disruptions that this could create, and how we can reflect, relate, and find a relevant and, you know, relevant strategies that could help both the organizations and the providers. Thank you so much for listening to me, and I'm so sorry about the internet disruption, speaking of disruption, and I hand it back to Nadine.
Thank you so much, Tanaz. I think it's so valuable to have the TVIC principles grounded in the actual experiences of service providers and organizations. And Tanaz did an incredible amount of work interacting with settlement services and other organizations to really see how TVIC was taken up. So I just have a few more slides to talk a little bit about TVIC first as a key dimension of equity-oriented care, or equity-oriented services. And, you know, acknowledge that in our model of equity-oriented care, it really is, TVIC is one of these three components. We've worked a lot in our Equip Healthcare research, so the URL is there, with different healthcare organizations in particular, and really looking at issues of stigma around substance use, and trying to reframe actually even our language from talking about substance use stigma or harm reduction to substance use health. recognizing those intersections I mentioned earlier with chronic pain and trauma and violence experiences, and then really focusing on anti-racism and anti-oppression work and creating that culture of safety. So really trying to get to the third tree there, where people have what they need, even if it's not the same across every person, such that they, you know, can get the apple off the tree, and making sure that the tree has enough apples for everybody. You know, this is a sort of new configuration of these trees than some of the ones you might have seen before. So I just wanted to emphasize that, because some of the tools I'll show you actually come from Equip Healthcare. So briefly, and I think I've mentioned some of this, so I won't spend too much time, but really taking that anti-racist lens is sort of challenging the organization to examine their biases, and it sort of links back to that notion of implicit bias I talked about before, and really focusing on the welcoming aspect of those spaces. Tana's mentioned just seeing signs in your own language can make you feel that you belong in that space, and that's a really important way to start a good interaction. So as a service provider, you actually want your client in a good place so that they can interact with you. They are, you know, taking in what you're saying, your suggestions, they're being, you know, interactive and are able to tell you what they might need. If people are in an activated state, that won't happen. So it's to the benefit of both the organization and the provider to make sure people are as calm and ready for that interaction as possible. And your space does have a lot to do with that. And really looking for those partnerships across with your clients and also advocacy groups, but other service providers. In London, what we've tried to do and are promoting is a trauma and violence informed community, so that wherever somebody goes, they're getting this sort of care. This culturally safe and anti-racist care. Oops, sorry. And then, as I mentioned, you know, I was quite new to the area of substance use, stigma, and harm reduction when we started the Equip work. It is a particularly nasty form of stigma, I have to say. And it is so, if you step back and think about, as I mentioned before, if you're, you know, a middle-class white person drinking alcohol, there's no stigma around that. There's all sorts of jokes about, you know, mommy's having their glass of wine and so on and so forth. In fact, you know, in some cases, if you don't drink in certain social situations, you're stigmatized for not using alcohol. But some, you know, some other people using alcohol are highly stigmatized. And I always think of the case of Mr. Brian Sinclair, who visited an emergency department in Winnipeg and, you know, had not been drinking. An Indigenous man had not been drinking, but the staff assumed he was, and they ignored him until they found him dead almost 2 days later, when he was probably suffering from a stroke. So that perniciousness, that you know, horrifying stigma has real world consequences and is really tied into racism, sexism, et cetera. And we really have to think about those things and examine our own biases. So how to get started on TVIC? This is just the intro, right? And many organizations have started to do this work. But as an individual, I would say, you know, start thinking in a TVIC way. Tanis gave you lots of good examples as she worked through some of the data from her work. But, you know, instead of saying, you know, he's weak because he drinks, wow, he's strong for surviving everything he's survived. Or, you know, she's unable to cope. Well, you know, she has a lot of survival skills. I'm not sure I would have gotten through this if I had been through these experiences. So, you know, on the left here is what my good friend and colleague, Vicky Smyth, would call stinking thinking. Get rid of the stinking thinking and start thinking in a TVIC way. Think about strengths, think about agency, connection, choice, those sorts of things, and think about people as survivors who survive and thrive. And that is reflected in language. So again, I won't go through all of these examples, but we do want to avoid stigmatizing language. We don't want to label people. So we want to talk about maybe people who are using substances, because they might not always have or will use substances. So you want to give that idea of a trajectory of hope. If you slap a label on somebody, then it makes it sound like they are not able to change. So really think about that, not only in your mind, in the way you think about people, but also in the way you talk to them and in the way you talk about them, either, you know, with colleagues or in a chart or other documentation, because words in a chart can follow people and be extremely harmful the next time somebody has an interaction, especially if they're labeled, for example, as drug seeking in a chart, in a medical chart. So you want to really, you know, emphasize positive language that is strength-based and non-stigmatizing. Tanis mentioned the trauma review exercise. So this is a link to some of our resources. We have a companion resource at Equip called the Equity Walkthrough, and there's a video also available in French, as well as a downloadable tool. So the trauma review exercise and the Equity Walkthrough are quite similar. They have slightly different emphases, and there are instruction sheets and walkthroughs on how to do this. So that's a really good place to start as an individual, if you just want to think through what it might be like for somebody in your space, but also then as a team, and very importantly, with some people who use your services, and have that conversation about what can be changed. Often these changes are not expensive. As Tana said, it doesn't cost a lot of money to put an extra sign up that's got local languages that welcome people, or that make sure people know where the washroom is and that you need a key to get to the washroom. It can be very stressful to wander around looking for a washroom, and that again can make the subsequent interaction, the care interaction, less positive than it could have been if you created those sort of welcoming and calming situations. So trauma review or equity walkthrough, really good place to start. If you want to sort of up the game to the organizational level, at Equip, we've developed a suite of tools, these discussion tools called Rate Your Organization. We actually have them across the different key dimensions I mentioned before: substance use health, anti-racism and cultural safety, and then this TVIC one. So there are actually 10 questions. I've just put 5 up here as an example. And then basically what you can do as an individual team member is go through and rate the organization, and then have a team meeting and discuss, what people are seeing in terms of what's already there in place, and what could be done to become more trauma and violence informed. So this is a good organizational change tool to get you started. We also emphasize, we talked a little bit while Tanis was switching devices about vicarious resilience. And we emphasize the role of the organization in supporting staff well-being. So as leaders of organizations or leaders of teams, really look at the ways in which staff are enabled to be well. And it's not enough to just say, okay, off you go, do some self-care. First of all, there has to be the structure for self-care. As Tana said, if there's no time for a break, then telling people to have a break is not a particularly good strategy. But here are some of the things like education, employee assistance programs, staff education, and then the notion of sort of debriefing and reflective supervision. We also want to do these things in a trauma and violence informed way. So you don't force people to debrief if they're not ready to debrief. And there's actually some evidence showing that forced debriefing can be very harmful and re-traumatizing for people who have gone through vicarious or direct trauma. So you want people to have choice and agency as to when and how they debrief, whether it's formal or informal. But as a supervisor, you want to provide the space and the opportunity for that to happen safely. So we do have a tool that breaks some of these things down, and the link here is at the bottom. Then sort of the Cadillac version is this new action kit that we've developed in terms of organizational change management. It's based on an implementation science model. If you really have some time to read, Tanis's dissertation walks through the active implementation frameworks as a model for organizational change and implementing TVIC. The doors here on the left are those 3 key dimensions of equity-oriented care I mentioned. So you can go in the TVIC door, and then we provide tools and resources to support all of the different steps to actually making change, recognizing that, it's recursive. You have to sometimes go back, re-look at your priorities, at your commitment, at your leadership and resources. You've got to monitor your progress, and then embed those metrics back into your quality improvement and ongoing, momentum. So we've got even tools like responding to resistance or anticipating resistance. There will be resistance when you try to make change. When you ask people to confront racist practice, for example, there will be resistance. So we've created tools to help counter resistance, as well as many other learning tools. We've created curriculum. So the TVIC Foundation's curriculum has many of what we talked about today fleshed out. Many of the beautiful illustrations that were in our slides are actually from these curricula. So very much encourage you to do this. It's free online at the URL above. You can stop and then come back. You'll be back in the same place. It's housed on University of British Columbia's Canvas learning management system, a very nice system. And you get to download a notebook where you have your own personal reflections and provide links to resources. So these are some of the cases from the foundations. We also have a new module that supports, in this case, public health nurses who do home visiting practice. I think there might be some interesting things in this module as well, in terms of those of you who do visit your clients at home. It is more towards nurses, but I think there's some good strategies around home visiting and creating safe interactions when you're in other people's homes. I've taken some of the images that I thought might be more relevant to those you serve. We have cases, obviously, that aren't only, you know, among newcomers from the Middle East. They are from different aspects of people that we might see here in Canada. And then we have a new book coming out very soon. We wanted to use some of Tanis's art on the cover, but University of Toronto Press was not able to do that. But this handbook will have a pre-order link by the end of the month. And I think the print copy should be coming out in May. Very excited about this. Some of Tanis's work, some others on this call, Jen Sandu, Emery Sanchez, will also be represented in this book as chapter authors, and some of their wonderful insights are available there. So that is what we have. I'm sorry, I've only left 5 minutes, but we did have a few extra minutes before for questions. So Sajde, tell us where we're at, please.
Excellent. Thank you so much, Nadine and Tanaz, for your excellent presentations and sharing some tips and tools and resources. It's a very rich conversation. There were a couple of comments. Kaylee, if we have time to take questions or not.
Yeah, we have 5 more minutes, so yeah,
okay,
go for it.
So let me see, where's the chat?
I hope everyone had a nice wellness break, got to stretch themselves a little bit. I know it's a long day sitting in front of a Zoom screen, but we will be finishing the day with a wellness activity led by Sajde. So please stick around until then if you can. I guess I'll get started. Hopefully everyone has come back from their break. So I'm very excited to welcome the presenters for this afternoon panel discussion. The topic is carrying on from the previous webinar that we just had. The title is Trauma and Violence Informed Care, Implementation and Practical Implications for the Settlement Sector. But first, I would like to start off by introducing the moderator for this afternoon. So Jennifer Sandu with MSW is currently the Community Engagement Specialist at the London Crosscultural Learner Centre. She holds a master's degree in social work from the University of Windsor. Jen focuses her work on building capacity around the needs of newly arrived government-assisted refugees. Jen was also a subject matter expert for the Immigrant and Refugee Mental Health Project for the Center for Addiction and Mental Health, CAMH, Special Populations Course, Yazidi Refugees in Canada. Prior, Jen was the Director of Client Services in Windsor, Ontario, supporting individuals living with HIV/AIDS, and as a case manager at CCLC, London Cross-Cultural Learner Centre, working with newly arrived refugees. Welcome, Jen. Thank you so much for moderating this afternoon's session.
Great. Thanks, Kaylee, and thank you to Sajde. Thanks to OCASI for having me. It's a nice full circle moment. I was presenting with Nadine back in 2020 again. It's a nice full circle moment being here, and really it's such a huge privilege to work and highlight our experts on our panel today. And thank you to Nadine and Tanaz. They both provided an excellent primer, and really grateful that we get to sort of jump even more into implementation and practical considerations. But before I introduce them, a few housekeeping details, very similar to our first session. We will be formatting the session as a panel discussion. I will begin by introducing all the panel members, and then we'll be giving each of them an opportunity to speak about their relevant experiences. Please hold on to your questions until the end, or you can type them into the chat as the presenters go, and we will make sure to record your questions to discuss at the end. We have lots of time to discuss things, so feel free to engage throughout or at the end. We will have time again at the end to discuss anything that comes up during the webinar after all 3 presentations. So first, it's my pleasure to introduce Anne-Marie Sanchez from London Intercommunity Health Centre. Anne-Marie is the Director for Strategy, Planning and Healthcare System Integration at London Intercommunity Health Centre, and she is a senior leader most responsible for the centre's newcomer clinic. The health center provides the most marginalized members of our community with access to comprehensive health care, including primary health care and community supports. And the newcomer clinic provides health settlement services and supports to government-assisted refugees for the first year in Canada. Anne Marie is also a member of the executive committee for the Center for Research on Health Equity and Social Inclusion. So welcome to Anne Marie. Our second presenter is Susan McPhail, independent facilitator, educator, and consultant on trauma and violence-informed care and cultural humility. Susan has worked in direct services and in leadership in social services and health sectors for the past 4 decades, with individuals and communities who experience multiple social and economic inequities and marginalization. Her background of working with the intersectionality of homelessness, adverse mental and physical health, substance use, trauma and violence, racism, gender-based violence, colonization, refugee newcomer experiences have led her to co-initiate several innovative programs, shelters, and services. In addition, Susan participates in community-based research to promote equity, community wellness, and safety for all. She currently works independently across many sectors, providing trauma and violence-informed care and cultural humility, consultation, training, and facilitation. And last but not least, we have Hannah from CCLC. So Hannah Akulali is a case manager at Crosscultural Learner Centre in London. She has been an advocate for many clients to navigate resettlement, as well as throughout Ontario healthcare system over the years, and strongly believes in a holistic, strength-based approach to case management and client well-being. Hannah is also an active member of CCLC's TVIC committee. She has in-depth experience with training internal staff and external service providers on TVIC practices. So really pleasure to invite them all here. And I know we're going to learn a lot from their insights and expertise. So with that being said, I'm going to pass it over to Anne Marie.
Awesome. Thank you so much, Jen. And thanks everyone for coming here today to participate in this panel. I think there's going to be lots of shared learnings that we can learn from one another. I'm just going to set up my screen now for my presentation. I have a pretty quick presentation. It's more talking points more than anything, just to go over our experience with equity-oriented care and TVIC. Okay, let's see. Okay. Oh, here we go. Okay, can everyone see my presentation? Hopefully I can get a thumbs up somewhere.
Yeah, we're good.
Yep. Okay, perfect. Thank you. So essentially what I'm trying to focus on is more our organizational implementation around equity-oriented care. So that's our, as you learned in our previous session, more of an umbrella term with regards to trauma and violence-informed care, but also harm reduction and cultural humility and safety in our approach to care at the health center. So hoping to provide you with more of an organizational example of our journey, but also give some examples that were more specific to our newcomer clinic as well. So just as a background, I'm not sure if everyone's familiar with the community health center model, but here in London, we're a health center that provides primary health care to marginalized groups across London. So that's not just your physician and your nurse, but primary health care tends to be a lot more holistic. So we also have physiotherapists and dietitians and social workers, as well as system navigators, and diabetes educators, for example, all working within one roof, all trying to provide more comprehensive healthcare to our clients. Now, we're typically in larger cities, there's multiple CHCs and they would have a focus on different priority populations. Here in London, there's only one of us, and we try to care for most priority populations that would be marginalized here in London. So that would include newcomers, but it would also include people who use drugs, people who identify as trans, isolated seniors, francophones, and more. We have over 120 staff across 3 different physical locations. And just to give you some context, I think it's important to also recognize that we have multiple microcultures across the teams and sites. I think this is important to recognize when it comes to the implementation and just assessing our strengths and taking stock in our readiness and our in our environment when it comes to TVIC and equity-oriented care. So back in 2019, we did an organizational assessment. So we conducted interviews over multiple months with clients. These were interviews that were held in a room with a volunteer, so they would feel maybe a bit more comfortable than sharing their experience with a provider. So we made it very clear with clients that this would not affect their care with us, and we gave them lots of time to be able to go in depth as in terms of just assessing whether they feel like they belong here, whether they feel like it's safe in our environment. And there was specific questions that we were asked, and this is within an equity-oriented toolkit that we were using, the Equip toolkit that Nadine had mentioned in the previous session. And so we took some lots of time and care in gathering that feedback, and we also took into consideration, just in case someone felt triggered, if they were maybe bringing up an example for an example that might have been traumatic for them or was not a good experience here at the health center. We also ensured that we had a same-day social worker there available to debrief or to reground the person after the interview. In addition, we have gathered significant and really rich feedback that way. And even though it took longer and it required a bit more resourcing, it was definitely worth our while. And then we also conducted a very extensive staff survey as well, trying to identify people's experience when it comes to equity-oriented care, their experience as a staff member and how the organization treats staff, the way they work with one another as colleagues, and then also their perspective and their experience in the way we approach care for clients. We also held walkthroughs with our leadership team, as well as our board and our community advisory council, so that people at the very top would have an appreciation of what we were doing. This also helped people understand that there was still, even though we might be have a significant health equity focus, there was still lots of room for improvement. And we also had some significant strengths that we could work from as well. With that information, we thought it was best to tie it into our strategic plan. So we, when we did our environmental scan for our strategy, and we ensured that we looked at different stakeholder engagement and stakeholder voices within our strategy, we ensured that all the data that we received or that we gathered from the Equip data and the survey, so our client survey and our staff survey, were shared with leadership and with the board as they tried to determine our strategic directions. And from that, we ensured that our strategic directions included a well-engaged staff and well-cared for staff, as well as for the health center to become health equity champions. And that really helped us in our decision-making and in our planning in the years to come when it comes to equity-oriented care. So we passed our strategic plan in February 2020, and then COVID hit. So that definitely was something that we were not expecting, but in some ways, it didn't matter. It may have derailed our work plan in our very tactical ways that we were going to implement TVIC and equity-oriented care at the health center. But given that our strategic directions already had some of that embedded, it really helped us when it came to our decision-making and how we were going to approach our COVID response, as well as our other initiatives and how we were going to prioritize our work in the years to come. Now that it's 2022 and we're on the other side, we're not to say that COVID's over, but we're not in that emergency crisis phase anymore. Based on some chart auditing, some quality improvement work that we were doing, we thought it was time to reignite some of this work and really focus on our trauma and violence informed care approach to care, and that's going to be our focus in the next year. So it may feel or it may sound like we had a bit of a pause, but it just made the work look different. So when it comes to equity-oriented care, but we never lost the sight of our North Star when it came to equity-oriented care. So some examples of client experience improvements or how we incorporated equity-oriented care was really, one of them was at a big level, our systems advocacy when it came to our COVID response, when we were at tables with the health unit, or whether we were at tables with the city, and how we were going to shelter folks who might be at risk of having COVID, or who were experiencing COVID symptoms, and how we were going to isolate them. When we were advocating for our clients, we always had trauma and violence informed care, cultural safety, and harm reduction in mind, because it was often a lens that was sometimes overlooked by our local or regional partners. So that was like at the height of COVID, when we were all kind of running around with our heads cut off, figuring out what we wanted to do. And then even later, maybe a year into COVID, our responses still had that equity-oriented lens in mind. So, for example, with our newcomers, we partnered with our settlement agency, so Crosscultural Learner Center, to provide vaccine clinics at our clinic, but also in community. And we really relied on the relationships that CCLC had and community relationships with our newcomer folks to ensure that we could provide appropriate education and information with regards to vaccines, because a lot of our newcomer clients had vaccine hesitancy, and we had to have a completely different strategy when it came to providing education and access to vaccines than we did with our other clients. We also worked very closely with the primary care sector and the health unit in how we were going to provide vaccines to different newcomers. And this included newly arrived newcomers within, they had just arrived within months, and also some of our newcomers who may still be rather insulated in their own communities, even though they've been here for 5-10 years. And so we really tried to have a more customized approach. Another outcome during COVID that was definitely geared towards equity-oriented care was a lot of people weren't engaging in community in the same ways. So we developed a program where we have a mobile bus where we provide primary health care into community. So the harder to reach folks, or the people who are really disengaged within our systems, still had access to primary health care and social supports and community supports. And that was a collaboration with multiple partners, including paramedics, as well as outreach workers and our local regional HIV/AIDS organization as well. As well as another bright spot that we had was really just advocating for health equity-oriented care at all our tables, which has led to some opportunities, such as some great work that we're doing with our hospital in embedding more equity-oriented care within our emergency departments, but as well within our critical care units and family internal medicine units. When it comes to staff experience, again, it didn't go as originally planned, but we definitely learned different approaches to still ensure that we were providing better equity-oriented care as an organization. So first, we definitely encourage any staff-led initiatives. So in the last couple of years, we created an Indigenous Strategy Committee, an Anti-Oppression Inclusion Committee, all with how we can better serve our clients with regards to our Indigenous clients, as well as our more marginalized folks, but then also how do we care for our staff who may identify as Indigenous, or who may experience oppression through our different levels, our different systems, and within the organization, quite frankly. So as an organization, we had a commitment to support and encourage these staff-led organizations, as well as we may not have had as much capacity to do more formal training across our 120 staff. So a new approach is really trying to perfect as much as possible our hiring processes. So ensuring that we are hiring people who have a high degree of knowledge when it comes to trauma and violence informed care, as well as harm reduction and culturally appropriate care. So right from the outset, we knew that we were working with someone who understood the language and understood how to implement it or embed it in their practice. And we ensured that we knew this through the series of questions that we were asking, that were very focused in providing asking different scenarios or case studies, as well as their understanding of different philosophies. And then we also ensured that the second interview would be shadowing to see how they work with our clients or how they would interact with or engage with our environments in which we work. And now, like I said, we're looking at, this is the time where we do feel like we have more capacity and doing some capacity building as well as some training. And we'll be doing this at the health center. We're doing it across. We're doing an all staff meeting to launch some of this work. And then we took stock and people who already have, we did a little bit of a needs assessment to see people who already have a good baseline when it comes to equity oriented care and how they can be some of our champions when it comes to doing some of this module work and more specific work and training at the team and site level. And then we still have some future planning that we need to do in terms of how do we ensure that TVIC and equity oriented care is in our onboarding processes, and how we actually make sure that there's a bit of a system so that we're continuously checking how we're actually doing and what's our baseline. And that would be through like our chart audits, some quality improvement processes, as well as our client experience surveys to ensure that we are still providing a welcoming and safe space, and that the person's experience is not re-traumatizing, and we're trying to eliminate as many barriers as possible. So, when it comes to lessons learned, I think you just kind of have to ride the waves a little bit and understand that it's not always going to be perfect, and it's not always going to be, you can't always adhere to your work plan, such as, a massive pandemic is going to kind of throw things off, but you can still ensure that it's part of your decision making, as part of your everyday language, and how you're planning, even if it's in the immediate, and even if it's a sense of right idea, wrong time, but let's see what we can do in the time right now, and what are the opportunities of ensuring that this is still something that's front and center, and maybe not the perfect implementation or the traditional implementation that we were hoping for. I think it's really important to listen and to amplify staff voices. They have so much expertise, and it's important to leverage those voices as much as possible. But also, so one is to exemplify the expertise that we have in the room, 100%. But then also when they are saying, this feels like a lot, or this feels like even more responsibilities for me, and I don't know if I can handle more. We did experience some burnout and some people being really tired, and we had to, even though this is really important work, we had to sometimes either reframe it or slow down, or look at things that we may need, some foundational pieces that may need to be reassessed before we move forward. And that's okay. And I think I hope our staff appreciated that we heard them when they were saying, okay, I'm tapping out. I can't do this right now. Just and in context of everything else that's happening, or how tired we are, or how much turnover there is, et cetera, et cetera. I cannot emphasize enough how helpful it was to have embedded this into our highest level of organizational strategy, so we can talk about it at the board level, at the senior leadership level, as well as with our frontline staff, as to why we're doing this and how it all makes sense from a vertical perspective and a bi-directional perspective as well. So the staff-led initiative, the staff feedback is just as important as we're trying to implement this work. This kind of leads into a little bit of what I'm thinking here on this slide in terms of staff needs versus client needs. So ensuring that the staff are feeling like we're understanding the trauma that they've experienced, the ongoing trauma of the ongoing impacts of trying to help the clients that we serve, some of the most marginalized folks in our community. And what does that look like? And really just paying attention that their cup needs to be full in order for them to be able to serve our clients in the best way possible. So as leaders, it's our responsibility to ensure that we can do that to the best of our ability. So sometimes that is a debrief, sometimes that is take a mental health day, but then there's also times where they say, I cannot take enough mental health days because this work is so hard, and we have to hear that too, and see how we can advocate at a systems level to try to really change the way things are working right now, because it's not sustainable for a lot of our staff, and we're losing some great staff at a community level or at a systems level, because some of the change needs to occur. It's bigger than our organization, and it needs to occur at a systems level. And then, of course, just appreciate the bright spots. I think it's important to say, actually, you know, how we flipped our hiring practices, that's a win. Maybe that wasn't in our plan and it wasn't our list of objectives, but that was a way that we were able to be adaptive, in a way that we were able to still stay on track as much as possible. Or, hey, yes, it's been a couple of years since we actually used formal training for some of this work, but we still think it's important, and we're going to do this anyway, and not be, you just accept that it might be taking longer, but also recognizing that, or appreciating the journey as you go along. And last but not least, similar, it's just being open to being adaptive to your implementation. So, you know, was it similar to what I was saying in terms about the hiring practices, but also, you know, a staff-led initiative that might not have been first on your list, but if it's something that they prioritize that's really important and then still aligns with the directions, let's go for it, and let's see where the energy leads us. And that might be just as impactful as things that you had originally planned. So that's what I was hoping to share today when it comes to implementation, and I hope it makes it a little bit more real and a little bit okay to have successes, but also some derailments as well. Thank you.
Thanks, Anne-Marie. I love your lessons learned. Sorry, just the ebbs and flows and sort of not having that sort of prescription. I think we all sort of need to normalize that and hear that. So thank you so much for getting us started. So now we're gonna pivot to Susan, and you can take it away. Susan, I think you're still on mute.
Yeah, how's that? Can you see my screen?
Yep.
Yes, we're good. Okay, great. Thanks. And thanks so much, Anne-Marie, for leading. And I feel like I might be just a bit of an echo, but I loved your presentation. It resonated with me very much. So you know, spring, I don't know about you, but I'm feeling like spring, please come. Today in London is sunny and beautiful, and I can almost smell it, but we know we have more to go. So I'm using a bit of a gardening theme, because when I think about planting, implementing, and caring for trauma and violence informed across our organizations and sectors and systems, I really think it's a little bit like a garden. So I'm using that as a metaphor. And I'm calling this Notes from the Ground. So I've had the great privilege of working within an organization, Canadian Mental Health. I was there for many years and helped to implement and grow and nourish and nurture trauma and violence informed across that organization for about 10 years. Great opportunity to work with Nadine and Tanaz, whom you heard from this morning, and have learned very much from these respected colleagues, but also most importantly, working with Crosscultural Learners Center, South London Neighbourhood Resource Center, JIAS in Toronto, Intercommunity Health at different times, and other organizations, and in particular, individuals who are part of community, whether they're working in direct service or they're accessing service, that really have been my greatest teachers. So I always like to acknowledge where I've come from and how fortunate I feel that I've had these opportunities. Now, why is it not? Okay. Is it shifting on your side? No?
No, not right now.
And it's not on mine either. Oh, there we go. Okay. So these are really reflections from especially the last few years, that although in the pandemic, many things ground to a halt, luckily we were able to transfer onto Zoom. And so I had the opportunity to do lots of training and consulting with multiple services and sectors through these last few years. Good. Can you see this? So what does it look like? Well, the pandemic has had enormous impact. And as Emery cited, many organizations that were well on their way or were beginning to implement, things really got quite derailed. And we all experienced a collective trauma. When we think about those features of what is a traumatic event, it's unexpected. We're not prepared for it. There's nothing that we could have done to have prevented it. There we all were. So we were grappling with not only how this was impacting us, our families and our work and the folks we were working with in community, but it was affecting everything that was before us in terms of our systems. And so if you know that term about being outside our window of tolerance, which is a really common term within trauma and violence informed language, we were really stretched. And the other thing that happened for a lot of us is there was significant change in leadership. There was a lot of staff turnover. And so we saw lots of disruption and change. Not only that, we saw significant increase in collective and interpersonal trauma in systemic and structural violence. And so, ugly things around racism, Islamophobia, gender-based violence really became front and center. And so there was really an increased significant demand for support. And then as Anne-Marie cited, we were caught in that in-between place of how do we balance the incredible needs of the folks we're working with and with our direct service staff. And also, as Anne-Marie cited, we've seen very high levels of what I would call moral stress amongst direct staff, as well as occupational stress and injury, and just a sense of fatigue. And in some of the work I do work specifically with leadership, and I've just seen leaders also exit, as I mentioned before, and also just be really tired. So it's hard to keep trauma and violence informed and cultural humility front and center, and it's really hard to continue with some of the plans that we've had, and yet we probably need it more than ever. So I echo what Anne-Marie said, is to, go gentle, go easy, do the best we can, start small, be very nimble, very nimble. So try new things. Something doesn't work, that's okay, tweak it, try something else, be prepared to have things not work, and just restart. So when I think about it, I'm always thinking about it from a very broad basis. So what does it look like? What does it look like at the service level for the person walking in our doors? What does it look like for direct service, for our organizational level, for the systems and the sectors we're swimming in? And then what does it look like for our neighborhoods and our communities? So balancing all these lenses, I think, is really important. And so what I find it's very simple, but I just always go back, especially sometimes I'm called to consult on some really complex cases. And I find if I just go back to the basics of the very basic principles and basic practices to use as my tools for the garden, and so what do we need for this and what do we need for that? And so just to refresh ourselves. And, it may sound simplistic, but I find we just can't go wrong. If we're kind of laying that as a lens, if we're thinking about staff care, if we're thinking about leadership, if we just lay this as a lens, we really can't go too wrong. And it's for me, a comfort and kind of a guidepost to help us get to the next step or when we're feeling really stuck. So I thought I would just share a couple of examples of things in recent years that I've come across that maybe can illustrate this. 2 specific examples. So just to say, I've worked across multiple sectors in the last few years. I did a lot of work with policing, which I think it can be encouraging. So they are attempting in our municipality anyways, and another municipality to implement trauma and violence informed as a practice. But also within settlement sectors, public health, homeless serving, mental health, etc. And I'm finding that there are just so many parallels across all sectors in terms of the implementation. So if I think about these, but I just want to say that both these case studies I'm not going to use any identifying characteristics, and they come from different areas. The first one is within newcomer immigrant refugee organization, and it was a situation with a woman who had had some very severe war trauma of a very violent nature, sexual violence and other kinds of violence, and she was presenting in to staff and to the organization as people had just sort of thrown their hands up, not knowing exactly what to do and how to help, because she had multiple diagnoses. She'd been reunited with her husband, that they had been separated and reunited, and they were here as a family. But she was presenting all the time as very flat, often going into really catatonic states, multiple calls of ambulance to hospital, multiple hospitalizations, lots of medication, very, very poor hygiene. So presenting, not caring for herself, hard to care for family. Husband, who was, fairly outgoing person, was really frustrated, and staff were kind of exhausted, and they just came to kind of a dead end about what to do. And we formed kind of a circle of care. I call it a trauma and violence informed circle of care, to sit down and really take these principles and really think about the case from outside how we might consider seeing it. So just to make a long story short, it was identified that in fact there was a tremendous amount of gender-based violence, interpersonal violence going on in the relationship. And calling in allies, building those relationships, looking at what would be some strategies to support her in particular. The transformation, quite frankly, was unbelievable. We also had to do some adjustments in terms of staff, but for us, it was a really wonderful example of how looking at a situation from a much broader lens, a trauma and violence informed lens, really lent a completely different outcome. And so that's the first case. The second case was of a family, a single parent family, where the young, it was with a large number of children, but the older children who were in their early adolescence had really taken over the care of the home, because the mom was really unable to care, and the family was at risk of possible apprehension through child welfare. And staff identified this would be catastrophic for a family who had been through so much. So again, calling on allies, developing that trauma and violence informed circle of care, looking at what was happening within the family from a broader perspective, bringing in other allies, other community partners, and creating multiple creative kind of innovative strategies, not only preserved the family, but supported the woman into a very different place. So again, if we think about those principles, understanding and thinking about the situation from a different lens, supporting the building of collaborative strategies across different sectors, and listening to the needs and the voices of the individuals who are involved in a different way, perhaps stepping outside what we think we're seeing and enlarging that view, can really change the situation. So just with that in mind, a couple of practical things. So I think that one of the most important aspects of trauma and violence informed is that inclusion, the sense of collaboration. Those sometimes are our very best resources, is that if we can pick up the phone because we know someone to call, rather than formally inviting that person to the table, that sense of knowledge exchange and mentoring each other. One of the things Anne-Marie talked about was onboarding. So when I take it to a different level in terms of the organizational or the team level, the things Anne-Marie spoke of exactly within the agency I worked at, we declared ourselves to be a trauma and violence informed agency. We changed our language on our job applications, exactly to what Anne-Marie said. We changed entirely how we did interviewing. And in terms of when staff were hired, we did an onboard process. There was a mentoring process, and those things embedded in the organization can really lend to strengthening the sense of not only valuing staff knowledge and but also cultivating what I call champions across the organization. So I think that when we're looking at implementation and really invigorating and keeping it, the probably most important folks are folks who are accessing our service and ensuring that we're hearing from them and what's making a difference and how is it working or not for them, but also valuing and the knowledge of direct service staff who often know far more beyond leadership. With that in mind, I also want to make a note that, because I do a lot of training across organizations, that it's really important to what Anne-Marie spoke of, that leadership at all levels, and particularly board levels, are included in this implementation of trauma and violence informed. At the board level, that's essential because of strategic direction, because of resource allocation, and because of, in particular, really being deeply committed to building an organization that prizes and values staff wellness as a central, because if that's our most important resource as an organization, if we don't have a well and healthy staff resource, we don't have anything to offer. So again, I just want to reiterate that what's really important too is to take it beyond and to begin to see it as a larger multi-sectoral initiative. So a couple of examples I can share with you is here on Perth County had decided multiple agencies sitting at collaborative tables about 5 years ago decided that they would implement trauma and violence informed across their region, across multiple sectors, knowing that we may have different mandates and different criteria, but if we can speak the same language and come from the same perspective, we're going to have much more success in the work we do together and much less frustration, because you know yourself that sense of, you know, the one organization is attempting to come from a particular perspective, such as trauma and violence informed or cultural humility, and banging up against or really finding those places of tension, because working with other organizations that are coming from a very different perspective. So we did some work in Huron County, and well, I would say almost every organization had committed to that. And we're just looking at redoing that work and reinvigorating that work. So again, just like everything we do, it really is cultural transformation. We're not looking to just check the tick box that we've received that training and now we can go on. We're really looking at how we can keep this alive and fresh, because the pandemic has changed everything, but also because we change, you know, staff change, leadership changes, and the conditions in which we are working within change. So it's important to keep that cross-sectoral view alive and well, and to nurture that too. So I guess what I want to say is that we want to plan and plant trauma and violence informed care, because I'm a great, I love culture humility. I love that work. I find it so elegant and so deeply respectful. Interestingly enough, I'll just share a little story that, you know, in one region I worked in Grey Bruce and other regions across the province. And when I was doing some work in Perth County, they were going to start with trauma and violence informed. And then when they really looked at it, they said, you know, we really feel strongly that our region needs cultural humility first. We feel like that's the first step for us. And I think they were absolutely right with that. And so they really worked, they just immersed themselves in that beautiful work for a couple of years. And then they went on to work and integrate trauma and violence informed. So, you know, plan with care, nurturing each step, just like we do with the garden, right? Growing takes time. So again, you know, be ready to change the plan, just like in a garden, you know, something's not working. So we change the plan. observe and reflect, really listen to those voices, particularly at the direct service level, and most particularly at the folks who are accessing our service, adjust as needed, and also less can be more. So try not to overwhelm ourselves by doing everything at once. But as Emery said, try to get a couple of good wins in there, because that will really make the difference to carry on. So thinking of a garden, cultivate your soil, create those conditions to support the growth, expect unforeseen and off seasons. It's going to happen. Call in as many helpers and allies as you can. And most importantly, just stay with it. So I like to say, plant trauma and violence informed, plant a tree to save a life. Well, you know what? Plant trauma and violence informed, because it really literally saves lives, and it grows and helps our communities flourish at every level. So I love this quote: the best time to plant a tree was 20 years ago. Well, the second best time is now. So the very best time to plant trauma and violence informed is now. And I always end saying, okay, what are you going to do this week? Because you can start now.
Thanks so much, Susan. I think every time I hear you speak, I learn something. So I wrote notes as you were going. So thank you so much. I love your analogy around gardening and nurturing and growing. And I think I'm going to be reflecting a lot on that. Yeah, a lot of really wonderful takeaways. So thanks so much. I think we're going to transition now to Hannah.
Thank you, Jen. And Susan, your presentation was inspiring, absolutely, especially the end part. I feel like I'm very inspired by it. So thank you for that. So before I begin, I guess, my presentation, I need to kind of highlight who the real champions are of TVIC for our organization. And Jen, yourself. So Jen Sandhu was definitely a big push, as well as Deb O'Grady, who used to be our HR manager and has moved up to bigger and better things. As well, I understand Dr. Tanaz and Dr. Nadine. When I was looking at your presentation, my mind was just blown, because I feel like that was everything we must have learned from you and your work. Those are a lot of the exact principles that we've been training our staff on and using during our trainings. So your work, it just goes to show how valued it really is. And so I'll move on to the next slide here, please. So you can see that the three categories, I guess, with our determination and during our journey towards TVIC, they're kind of very much interdependent and intersecting in a lot of cases. It just goes to show that the organization and its role and its response is just as dependent on the staff experience and the client experience holistically. And they all kind of have to intertwine in this odd little symbiotic relationship. So that's what I'll be focused on throughout my presentation. And on the next slide, we'll be starting off with the client-centered approach that we like to take and use during our trainings. So if we move forward, the first thing we tend to focus on, one of the first things during our trainings, is the recognition of unconscious bias and what that means for our staff and our clients. And when I was saying that the concepts intersect, because we literally do have a lot of our staff that have gone through the lived refugee experience, and we're resilient enough to kind of be able to move forward through post-traumatic growth and finding a job, whether it's at our organization or another. But it's just understanding your own unconscious bias regarding the situation or the experience, and the fact that some of our clients may not have experienced it the same way you have. A lot of our staff members say, well, I went this, or I came this way and I'm fine and I moved on. Why can't they do the same? Right. So it's just kind of internalizing and recognizing that not everybody will have the same experience. And of course, becoming aware of our own traumas and triggers and how they manifest with our colleagues and our clients. And another thing we like to consider with our trainings is the terminology that we use to describe kind of the onset of arrivals that are coming, right? We tend to think of refugees as flows or waves. You know, we have the Afghan wave coming, or the Syrian wave, or the pools, floods of migrants, right? So it's just kind of considering and recognizing the impact these images have on our attitudes and the way we serve the clients, and in the ways that we discuss the clients, right? And so I ask you to consider the same thing: is how does this terminology affect your service delivery model when considering TVIC? And if we move on, the reason why it's important that we have the distinction between the refugees and migrants, given everything that's listed on this nice little chart, is the importance when considering equitable services, right? Is recognizing that these groups are not homogenous, they're not the same, their experiences are definitely not the same. And with that being said, as a settlement agency with providing settlement services, we have to consider that therefore a one-size-fits-all approach to trauma and violence informed care cannot be used. And that's something we've kind of revisited as the TVIC committee with our committee heads as well, is just having to revisit some of the implementation of our services. And as a result, we recognize that each of these categories have the unique needs and unique outcomes as well. And so if we move on to why this is important, it really does put everything into perspective and acknowledging the systemic challenges. As Susan mentioned earlier, the beautiful notion of practicing cultural humility, it really does help us move forward in acquiring and practicing cultural humility and cultivating an environment of cultural safety when providing our clients services. And it helps us kind of understand the difference as well between individual and collectivist cultures. We understand that living in a Western society, we tend to be more of an individual, right? And you have parents that, you know, want their children out by a certain age. Well, that's not necessarily the case for families that have been arriving and, you know, the elder generations of brothers and sisters are still very closely knit, and they still want to be able to either live together in the same home or live at least within the same neighborhoods with their own children alongside, right? So that's a lot of things that we have to consider on different levels when we try as best as we could to accommodate our clients and their needs and their community requests. Another example would be the Yazidi community. We know that given their history and their cultural beliefs, it is important for them to live together as a community and not be dispersed. And that was something we really had to take into consideration as an organization when our resettlement and assistance program team had to find housing, is trying to find housing for all these families in individual cases close to the same community so that they're together. On to the next slide. So I understand Dr. Tanaz talked about strengths-based approaches in building client capacity, but what I really love is the notion of client re-empowerment as well. It's the notion that the client has always had the power, individual has always had power, and it may have been taken away from them at one point, and our job as service providers is to try to have them recognize and kind of reclaim that power once more, right? And so the ways in which we try to practice that, of course, rebuilding and their idea and emphasizing their ability to take charge of their own well-being, so to speak. I know a lot of our colleagues would say, you know, we shouldn't be babying the client. We should really have them try to take charge of their own well-being at different stages that may look different, but the ultimate goal will be that. And considering, of course, equitable approach to services, So for example, not expecting a client who is illiterate with very low level basic life skills to integrate at a similar capacity as a client with basic literacy skills in their own language, maybe can read a few English words and letters, and has the basic life skills, right? So what we try to do our best at is tailor these settlement plans to fit the client and not the other way around, not having the client fit this organizational or systemic mold. So we do that the best we can with trying to play with our settlement plan. And we at one point we called the plan an empowerment plan, and it was doing just that. It was having, one of the questions was we asked the client what they feel their strengths are. And I remember we got a lot of blank stares during our assessments and visits, because the client was, what do you mean? What do you mean my strength? And so we'd have to explain it in different ways and others, just so the client understands that they do have the capacity to kind of cultivate their own strengths. And it wasn't a notion that was practiced or understood before. So using those kind of tools to ensure that the client kind of brings out their own strengths, and meeting the clients where they are and not where you expect them to be, right? I know that we all have our basic needs assessments and benchmarks that the clients have to be able to meet to move on with services, or to move towards citizenship. But maybe understanding that it's not going to look the same for that specific family or that individual. And then educating ourselves about the client and the collective community, their background, and this is beyond just the experience and what happened in the zone that they were in, right? This is more getting down to, again, the cultural humility practice, where you're learning more about what is okay and what is not okay before the client has to even tell you, right? So doing a little bit of research, talking to community members that were already here in London, finding ways to get into some of their pop culture, for example. Everybody loves, I remember the Nepali community, they love to talk about movies and music and food. So really getting into that and being open to it. And of course, being open to learning and consulting and working with alternative mental health service providers. I know we've mentioned this morning with Hung Fook, but also with Ayurvedic mental health approaches, and I know that there's an organization in the States called Maristan, and it's a Muslim mental health based institution run by a Stanford professor named Rania Awad, and the approaches that and the lens that she takes a look at from both a Muslim perspective and from a migrant perspective is completely different than the Western based approaches. So again, back to the cultural humility with that regard. And moving forward, one of the things we love at CCLC is our partnership with the Inter-Community Health Center, because just as this quote said by Dr. Mebrashid, is trying to get the client organized and set up as much as possible with primary care as early as possible. A lot of the clients come with really high needs that need to be kind of handled as soon as possible. So that becomes our priority with a lot of our government assisted refugees, especially, and recognizing that. I will very quickly have to go to this next case study. I'll head right through it. So we've had a single mother of 4 arrive at the center, and she was pregnant with twins from Syria. Unfortunately, the physician overseas had to forge her gestation date to have her leave the country in a timely and safe manner. And she ended up delivering within 2 weeks of her arrival. Her initial gestation date, what was on paper, was completely different than what we saw. And of course, the family had escaped a really dangerous situation, very traumatic domestic abuse situation, which is the reason why they had to get her on the plane as quick as possible. And one of the children was kind of more or less the target of this abuse. in comparison with the rest of the family members. And as a result, of course, she had a lot of chronic health concerns, especially mental health. And there were a lot of barriers, systemic barriers still were, there's still issues finding a family physician, as we all know. It's not, it's like finding a diamond in the rough these days. But she was beginning to kind of portray concerns the school was describing as manic episodes in the middle of the day or in her interaction with her peers. And so on the next slide, what we started to do was exactly what Susan said, establishing a circle, or sometimes it even looks like a web of care around the family, where they were kind of in the middle of this cushioning of services, just to make sure they were very well supported. Again, recognition of the Intercommunity Health Center, who really stepped up, and we had discussions about the family, especially the young girl, being referred over to the Resilience Clinic, and they do a lot of counseling, mental health supports. She fell in the gaps because unfortunately a lot of services either have huge wait times and she couldn't access them, or she was a little bit too old for some of the services. So again, we had to work with a lot of these finding band-aid solutions basically for these gaps to make sure the child isn't kind of lost in between. So that's the client component. We're going to move forward to the staff component. And some of the challenges, I'll dive right into the challenges first and foremost, we've had were how we addressed the structural barriers, and how do we measure and evaluate the progress is basically where do we start. And by we, I don't mean we. Thankfully, Jen was the one who kind of shouldered this in consultation with a few of our partners. And the key question being, how do we know that we finally become a TVIC organization, and have we achieved that goal? So I think the challenge was in the measurement, and of course in the staff willingness to participate in a lot of the TVIC initiatives. And so if we move on to the next slide here, we can see this is kind of like our journey on the way to becoming a trauma and violence informed care organization. Of course, it had to start with commitment from our upper management and board members. And then a lot of it really depended on our partnership with Western, with Dr. Tanaz and Dr. Nadine. And working our way up to, the awareness of compounding the training content, and training a lot of the trainers, and I was one of them. So having a whole committee of trainers basically that were armed and prepared to train the rest of the organization as needed, having the TVIC questionnaire prepared and revisiting it once in a while, right? So that was the structural review aspect. And then of course the maintenance. The maintenance, and I want to add the evolution as well, because through the years and with COVID, I think we've had to revisit a lot of what we've been doing and what it looked like, and we've had to tap into humorous type resources to make sure that everybody was still kind of light and not taking things with a it was a very depressing time for many. So just making sure that staff were practicing self-care during this time. And then with that, some of our successful outcomes, I think the thing that we're most proud of, it's on the next slide, thank you, is that we had to train everybody involved. And that means everybody from upper management, and the the frontline workers to the life skill workers and contractors that were involved. Basically anybody that was involved with client care, because we found it was very important, not just for frontline staff, but for the staff that were, let's say, teaching clients how to ride a bus, clients that were, staff and contractors that were working in the kitchens, anybody who had contact with the clients, not just for the client's sake, but for the staff members themselves. For example, some of the staff who were working up in our reception center, they were some of the first points of contact for our clients. So you can imagine that a lot of their stories were coming out to these individuals. So it was important for them to kind of be prepared for what was coming and how to deal with it, and to ensure that, you know, the staff were taken care of as well during this time. Right. The other thing we are kind of proud of is the transition that we went through from the Employment Assistance Program to Inkblot, which was back in November. And it was a far more online friendly service for counseling services that helped kind of better meet staff needs and busy schedules. So that was something that we found very successful, and having kind of an ad hoc work from home accommodation when necessary, just the flexibility of it, and understanding that, you know, some of the parents in the organization as well might need that here and there, depending what's happening at home. And on the next slide, of course, we find ways to keep TVIC alive in practice as much as possible, through debriefing and training on debriefing, keeping a TVIC newsletter going at least once a month at our organization for self-care practices for staff, and having leadership support and leadership support and department champions. Those are our committee members that kind of uphold the TVIC practices.
I'm so sorry. Did I go ahead or behind? I want to make sure I go back to the right slide.
I think you want to go maybe 3 behind.
Okay. Because this is where we were, right?
Yeah, this is it.
So sorry.
No worries. No worries. And of course, learning from our partners and taking baby steps and understanding that, of course, change and evolution takes time, and not being afraid to go back to the drawing board when things aren't working or when they need to be working differently. We do evaluations and make some of the adjustments that are necessary. So, for example, the Ontario right to disconnect policy, I think HR was definitely adamant about this policy at work, and just making sure that every department was implementing it and no staff was kind of getting to a point of burnout. I know that one of our speakers was talking about, you know, keeping our organizations open a little bit more or having staff available a little bit more. Sometimes that's just not feasible, right? Knowing that our staff have families and other commitments after their work time. And so understanding, and we do explain to clients, because it is important for them to kind of understand Canadian culture, to be able to work towards successful integration, is that we do have to turn our phones off at some point. And that is what the disconnect kind of entails. And we also use CTRI as a wonderful resource for our workplace assessment tool in determining whether our organization needed a little bit more work. And we determined some of the criteria where we need to do better. So we're still kind of working towards that as well. Now we can move forward. So in terms of modernizing our programs and services, it was kind of all about recognizing some of our pressure points, and the need to expand our teams by hiring more staff and allocating staff for evening and overnight work, where we were receiving a lot of arrivals in the middle of the night, and some of our staff were completely overwhelmed and overworked. So having to restructure some of those teams, and hiring more well-being counselors. And this is something I actually love to champion, because it's something our organization did successfully, given the challenge and the gaps that we saw in mental health services. We thought, how about we kind of internalize this? We started off by 2 initially. Now they've grown to 4, at least 1 per department, well-being counselor. for clients that need counseling specific services. And of course, we have a whole team that only just purely handles government assisted refugees. And so, of course, the other thing that we're really proud of is our partnership, like I said, with Intercommunity Health Center and reimagining the newcomer clinic and restructuring it in the sense that you know, they've created satellite offices in some of the hotels where our clients are. So kind of meeting the clients where they are and having primary care available and primary health screening available as well. Yes, of course, having wraparound care, case conferences where sometimes a few members of our organization are involved, but to be able to kind of streamline services and not work in competition. The next slide, there we go, thank you. So it goes again to show that we do try as much as possible to mitigate risk to staff by having the ongoing training. We do refresher trainings at our organization, and new staff training is mandatory, TVIC related for any new staff that's coming to the organization. And establishing the client charter. That's something that started with one of our departments, and now it's a center-wide thing. So it's kind of trying to mitigate risk from all angles of our work, and maintaining our community consultations and partnerships, and enhancing any collaboration efforts where possible. And then if we get down to the nitty-gritty, some of our recommendations on the next slide, where we've had to address and revisit our client charter, and make sure our clients understand that we do still need to establish healthy and constructive boundaries, and set expectations for behavior for the staff's sake, and for the client's sake. As I said before, it's important that clients do begin to kind of understand what is appropriate in Canadian culture and behavior. That's part of the growing and the post-traumatic growth process. And understanding that, you know, harsh and abrupt behavior or yelling or threatening is not something that'll be accepted anywhere, and it's not okay, because it's not going to be a positive reflection onto the staff who's kind of taking the abuse. So recognizing that there's no carte blanche for inappropriate behavior, but still trying to cater to the client's services and in understanding of TVIC principles and practices. And so what we try to do is definitely offer alternatives when necessary, and if possible, given the staff schedule and given what the client is able to do as well. So the lessons we've learned, moving on, is that there's always room for improvement. I think any successful organization that strives towards TVIC and TVIC practices becoming TVIC informed is that right now, as an organization, as a TVIC committee, we're working towards establishing safe spaces for staff, and we've had discussions on debrief protocols and having spaces for those debriefs. I remember one of the sessions this morning with CCS, the concept of having a debrief style cafe for staff to be able to come and debrief with one another and just have that kind of safe space. I love that idea, and I think I'm going to have to reconnect with you and take that back to discuss with our committee as well, because I thought the concept in itself was very comforting when I heard it as a frontline worker. And of course, we recognize that we're still having challenges balancing between prioritizing the clients, their needs and their services versus prioritizing the staff and well-being. And I think those things are just going to continue to be a challenge in finding a balance towards. But I don't think that's anything that we shy away from. And thank you very much for having me today.
Thanks so much, Hannah. And we're also so lucky to have you as a champion at the center. Hannah is really our lead trainer at this point. So she has an amazing amount of expertise. So thanks, Hannah. And I think thank you all to all three presenters. There have been such commonalities, which are so lovely between all three presentations. So, I mean, I made a ton of notes, but, just to sort of recap this idea of like circle of care, working on all different levels, working with a larger community. I really love the idea of being, adaptive and nimble, taking baby steps is okay, going back to the principles, really highlighting the need for structural changes, looking at the importance of leadership and onboarding, celebrating small wins. I probably could go on, but there's been a lot of unifiers between all the presentations. So thank you all three. So we definitely have a bit more than 10 minutes for discussion. So if anyone has any questions, feel free to put that in the chat. There's one there already. So Nada said, what about fostering and training volunteers on trauma and violence-informed care, especially in prevention and promotion and program services? So I'll throw that out to all three of you if anyone wants to start.
I have a feeling that was directed towards our towards CCLC. And I did forget to mention that, yes, we had our volunteer coordinator, and she had also been doing the TVIC training tailored to specifically to the volunteer groups.
Yeah, good question. Other comments? Loved all the presentations. Thank you so much. Love this presentation. The convoys planting a tree, really inspiring. Thanks a lot. So we can certainly wait for other questions. Hopefully we can have a really fruitful discussion. But I have lots of questions, so I can sort of get us started. So I was thinking a lot about this idea of sort of like buy-in. So it's been really hard, we've talked about moral distress, the turnover, all, competing organizational priorities, all the things that are going on. So can you speak to sort of, and obviously all three of you did sort of capture it, but I want to sort of lean back into this idea of sort of buy-in and how do we shape sort of organizational culture and sort of shifting to more equity-oriented and trauma and violence-informed care. So if anyone wants to jump in, again, sort of shifting culture, this idea of buy-in, is it realistic? If anyone wants to jump in.
I just want to, I'll jump in. I'll say that this is where I think champions really matter, because when we initially did, this is at Canadian Mental Health, very preliminary presentations on trauma and violence informed, my feeling always is that those direct service workers often know, breathe, live, and practice this. They may not have language around it, but it's much more respectful for them and the folks they're working with to be working from a trauma and violence informed way. So in every team and in every department, there's direct service staff who get very excited about this because finally you're singing from my songbook. And so I think that's how buy-in works, is by really valuing and including those champions organizationally on teams, and also empowering them to take those leadership positions. We often find that within trauma and violence informed, there's the formal leadership, but maybe what matters as much is that informal leadership. And there are informal leaders everywhere, right across the organization. So it gives folks an opportunity to really step into that role of leadership in a way that values their expertise and knowledge.
Yeah, I think that's great. And I remember, Susan, when you were sort of mentoring us, what always comes to my mind that you would say in the training that you're already doing this work, right? So, and I love that. And now I use that all the time. So thank you for that nugget of wisdom. Hannah, Anne-Marie, any thoughts?
I think, but I agree with Susan. However, I do feel like before we jump into staff buy-in, we have to focus more on staff retention and strategies for staff retention, because I feel like that's what a lot of the organizations, especially ours, is struggling with right now, is incentive and strategy for retaining some of our staff, and then having to go back to the board again and retrain all these new staff, and which creates a lot of pressure on some of what are now senior staff, right? So I think before we jump into the buy-in, I'm sure as time goes along and as staff become a little bit more ingrained into the organization and its culture and its practices, they will eventually buy in. As we mentioned this morning, I think staff and employees that are happy will be willing to work and do a little bit more, do a little bit extra. So I feel like that's where the focus should start first before we jump into the buy-in aspects of it.
No, that's great to sort of, and even the onboarding, retention, all those different pieces are important. Anne-Marie, any thoughts?
Yeah, it's interesting. I think for us anyway, as I had mentioned in my presentation, we have like some microcultures, and the teams that have to work with the most marginalized get trauma and violence informed care a lot more easily than those who may not encounter it in a more obvious way, I guess you could say. So they're not encountering clients who are in constant distress or crisis or whatever it may be. But so I think at this point, it is a combination of recognizing the champions, recognizing the excellent work that some are already done, that already exists, but then also saying, actually, this matters everywhere. And I think the walkthroughs have been helpful from a leadership perspective when our everyday work may not be as directly impacted. We're not working with clients every day, but it does matter when it comes to the way we plan, the way we make decisions, the way we advocate, those types of things. But when it comes to people like, for example, our operational team, so our finance coordinator or things like that, we do have to find different ways for them to understand how it impacts them as well. Even, for example, our janitor or whatever it may be. Actually, when you come and you clean up after a client of ours, that interaction matters as well. I think Hannah had made that great example in terms of the person at the reception desk or whatever it may be, might be that first interaction. So it matters at all levels. And sometimes you do need to be a little bit more explicit about that. But in terms of, so that's one thing, is for people to see it. But then I think sometimes we don't get buy-in if people, sometimes they get afraid that this is just more work or more expectations that they need to think about when they're providing care, when they're already exhausted. But what I love about the toolkit and the framework that we use is that it's also about caring about our colleagues and the way we treat our staff. And so once people start seeing that this is actually a two-way or like a multi-directional street, so to speak, I don't know if I'm using the right analogy, but once people start seeing that we also need to take care of our own first, then I think people start seeing the benefits of this work.
No, that's great. I love the idea of sort of the microcultures. I never sort of thought about it in that way. So I feel like that's a really good take home. And I agree. Even like the equip tools, the walkthrough we've used, I think there's a readiness checklist that we used way back when. So any tools that you can use, I mean, I think, Susan, is back to your point that like, go back to the principles and like, you're not going to go wrong. And I feel like I wrote that down because you're right. You're not going to go wrong. And any tools that you can use are just going to, you chip away at things and you're going to get there, right? So we can still wait from other questions, comments. Thank you, Anne, Susan, Hannah, very formative presentations. Thank you, Jen. Oh, thank you. So anyways, we can jump back into other questions I have here. So we know it's really important that we have sort of culturally integrated programming for newcomer communities. It helps build trust, helps sort of tackle stigma, but lots of times those programs don't exist. Or if they do exist, lots of times there's huge wait lists to them. So I guess throwing that back out to all of you, how do we sort of ensure that we do have really culturally safe and sort of integrated programming for our clients? Or how do we at least sort of incorporate that maybe into our everyday work? So I'll go to Susan.
I was just thinking you should go to someone else because I'm not situated within an organization. So I think I really am going to look to Anne-Marie and Hannah.
Sure. So it's wonderful to have partners that within the community, at least in London. We're small enough that you do have a sense of which organizations are working on this type of work. And through work, you do know if some people have, for example, really strong harm reduction principles or something like that, which is among the pillars, and you do tend to work more closely with them. But I do feel like this work is part of the frontline workers' job, but also I, at least as a leader, I carry that a little bit carry that a little bit more in terms of how we advocate for this type of work within at system tables and our partner tables, in terms of how do we incorporate it, how do we get funding for it, how do we ensure that our partners are constantly asking themselves these questions about how do we provide more appropriate care, what are the special considerations for people who are not quote unquote our mainstream clients, for example, from the hospital, those types of things, and even just putting yourself out there to see if you can draw up a partnership or whatever, or grant proposals to see if we can find funding for this type of work to work together. I do see that as part of the role of leadership to be constantly talking about it and asking those questions about how we're embedding trauma and violence informed care or equity work in what we do. A perfect example right now is in London, we're doing some health and homelessness stuff. And fortunately, we're at the table where we are looking at what are the values. And we, at least from our perspective, we're like, okay, where's the trauma and violence informed care? Where's the harm reduction? And where's the culturally informed care that we need to put right in front and center? And then we can walk people along in terms of what does that actually mean? How does this different than different approaches to care and stuff like that? So fortunately, if you do have that level of leadership, I think that's important when it comes to spreading and making this more about a community approach or a systems approach, as Susan was mentioning.
No, it's great, Anne-Marie. Hannah, did you want to add?
For my point, we kind of touched on that during the presentation, but I'll reiterate. I believe in Band-Aid solutions when nothing else presents itself, because we can talk about funding and grants until the cows come home. But if there's nothing else in place, I feel like using some of the resources that already exist and getting creative with them are kind of the way that's left to go when nothing else is existing, or if wait lists are too long. And so as an example, I've mentioned like our counselors. There's 4 of them now at the center, and we've noticed a little bit of a gap with a lot of our single mom cases arriving. This past year more, there's been a lot more than we've ever seen before. And it just seems that so many condensed challenges are around these particular groups. And so I think we just kind of had to get creative by looking out to our partners to see, even if you're not able to contribute the service itself, are you able to give us the space to run groups, for example, for some of these women in their own languages, for counseling and healing with childcare involved and things like that. So that's kind of a work in progress, I know, on our end, but it's the only way we can think of is in a sense needing to reinvent the wheel, because the other ones are already so severely overused and just no more capacity to take anymore. So kind of looking inside and seeing what more can be done and getting creative with some of the partnerships that already exist, and if they can't offer services, what can they offer at these times.
Great. Thanks, Hannah. Oh, go ahead.
I just want to speak quickly to this because I loved what Hannah just said and Anne-Marie. And so it reminds me of some of my earlier training, which was in community development. So we will really want to bring it back to community, in my mind, over and over again, because we don't want to be service providers forever. And we don't want folks to always have to have service providers be their community. We really want to find every opportunity we can to support the development of the communities that are there. And so just to what you said, Hannah, accessing other aspects of our community to help us to create space and to support initiatives and activities so those communities can tap into their own inherent strengths and capacities. And just one more thing I wanted to mention too, that I'm not sure I did in the presentation, is I talked about trauma and violence informed circles of care, but there's another concept called communities of practice. And so that was something we had attempted, and I would love to see across our community anyways, and that is cross-sectorally, establishing, noon hour lunches, communities of practice. We used to do this years ago, where people just brown bag it and come together to talk about the challenging cases they're experiencing and what are they doing, and to seek, those allyships and those collaborative partnerships, and to hear outside the box kind of thinking from other players in our community. So yeah.
Thanks, Susan. I think that's the, best place to end around sort of community practice, community development. And thank you so much, Hannah and Susan, Anne-Marie. It's always a pleasure working with you and learning from you. Again, I learn so many new things every time I get to work and listen to all of you. So hopefully to the audience, you've learned lots of tips and tricks and tools. There's no one size fits all approach. So hopefully, you can learn a little bit from us today and implement those in your practice and organizations. So thanks for having us.
Yes, thank you so much, Jen and Hannah and Anne-Marie and Susan. This was a fantastic panel discussion, and also it was really great to see all of your presentations. It was really just so informative to see concrete examples of how your organizations went about implementing trauma and violence informed care, some of the hurdles that you were facing, and then also how you were able to overcome them over the years. And I think it fits in really well with a lot of our discussion from this morning around some of the challenges we faced with the mental health promotion project and implementing the model, thinking about how it's challenging to build organizational capacity given these structural issues that we're all facing. So I think hopefully it gives other organizations on this call hope about what is still possible, even given the issues that we're facing. So I just wanted to thank you all so much.